Right. Good morning, members, and welcome to the second meeting of the Lincolnshire Health Scrutiny Committee for Lincolnshire. My name is Katrina Cope, and I am the Senior Democratic Services Officer, and I will be providing support to the committee today. Prior to the start of the agenda, can I please ask members to confirm you're present when your name is called? Thank you. Right. Councillor Suzanne Barker-Milan.
Present.
Thank you. Councillor Bill Bilton. Councillor Bill Bilton.
Hello, yes.
Yes, you're here. Okay, thank you. Councillor Chris Brewis.
Present.
Thank you. Councillor Matthew Fido.
Present. Present.
Thank you. Councillor Mrs. Sandra Harrison.
Present.
Thank you. Councillor Rob Kendrick.
Present.
Thank you. Councillor Carl Macy. Councillor Carl Macy. What's that noise? Councillor Colin Matthews.
Present.
Councillor Robin Renshaw.
Present.
Councillor Glynis Scalesi.
Trina, Councillor Scalesi is being given assistance to access the meeting. Thank you.
Okay, thank you very much. Councillor Angela White.
Present.
Thank you. Councillor Mark Whittington.
Trina, it's Simon again. Just to say that there is an issue with Councillor Whittington accessing the meeting at this point.
Okay, so he may come in later, the same as Councillor Glynis Scalesi. Councillor Stephen Woodliff.
Present.
Thank you very much. Councillor Linda Wotton.
Present.
Thank you. Councillor Ray Wotton.
Present.
And Dr. Brian Wookey. Dr. Brian Wookey, are you there? Yes. You need to turn your microphone on.
Yeah,
Thank you.
Can you hear me now? Present.
Yes, thank you very much. Thank you, members. Right, we now move to the first item on the agenda, which is the election of chairman. So could I please invite nominations for the position of chairman for the year 2021?
Thank you very much. Can I please nominate Carl Macy to be chairman for the ensuing year? I think said us very well, and I propose him.
Thank you. Do we have a seconder for that?
Yes, Trina, Councillor Ray Wotton, I'd like to second that motion. Carl has been an excellent chairman over the past year and shown leadership and support and believes in team working, so happy to support.
Thank you. So we have a proposer and a seconder for Councillor Carl Macy to become chairman for the Health Scrutiny Committee for 2021. Do we have any further nominations? Okay, in that case then we'll go for the vote. So if I'll read your name out in order, and if you could just please confirm whether you're for, against or abstain. So Councillor Susanna Barker-Milan.
For.
Thank you. Councillor Bill Bilton.
For.
Councillor Chris Brewis.
For.
Councillor Matthew Fido.
For.
Councillor Mrs. Sandra Harrison.
For.
Councillor Rob Kendrick.
For.
Councillor Carl Macy. Councillor Colin Matthews.
For.
Councillor Robin Renshaw.
For.
Councillor Glynis Scalesi, if she's managed to get in yet. Okay. Councillor Angela White.
For.
Councillor Mark Whittington. Still not managed to get in yet. Councillor Stephen Woodliff. Councillor Woodliff. Councillor Woodliff, are you having problems? Is it 4 or, yeah? Councillor Linda Wotton.
4.
Councillor Ray Wotton.
4.
Can I just go back to Councillor Stephen Woodliff? Was it 4? Thank you. I can see I'm reading his lips. Okay, so from the members present, it's unanimous for Councillor Carl Macy to be elected chairman for 2021. Thank you very much. Over to you, Chairman.
Thank you. First of all, I would like to thank both my proposer, Councillor Brewis, and seconder, Councillor Ray Wotton, for my nomination and the support of the committee in re-electing me. I look forward to the next year and our continuing scrutiny of our local NHS services on behalf of our residents. I'd now like to move into agenda item 2, the elections of the Vice Chairman. I would like to nominate from the Chair, Councillor Chris Brewis. Chris has been an excellent Vice Chairman and support for me over the last 3 years and has over 11 years' experience as a member of this committee and as the Vice Chairman. Is there a seconder, please?
Chairman, I'd like to second that proposal. Councillor Brewis has been an excellent Vice Chairman and I know he gives you full support. Thank you.
Thank you. Any further nominations? No, in which case I'd like to hand over to Trina to put the nominations to the vote, please.
Thank you, Chairman. Right, I'll read everybody's name out again then, please. So, Councillor Carl Macy.
4.
Councillor Susanna Barker-Milan.
4.
Councillor Bill Bilton.
4.
Councillor Matthew Fido.
4.
Councillor Mrs Sandra Harrison.
4.
Councillor Rob Kendrick.
4.
Councillor Colin Matthews. Councillor Robin Renshaw.
4.
Councillor Glynis Scalesi. She managed to get in yet? No. Councillor Angela White.
4.
Councillor Mark Whittington. I think
4.
he's got in. Thank you. Councillor Stephen Woodliff. You need to unmute your microphone. 4. Okay, I can lip read. Councillor Linda Wotton.
4.
And Councillor Ray Wotton.
4.
So that is unanimous, Chairman, that Councillor Brewis become Vice Chairman.
Thank you and congratulations.
May I also thank you, Chairman, and the committee. I'll do my best to support you and see that we do an effective job during the coming year. Thank you.
Thank you, Councillor Brewis. This is for the Lincolnshire Partnership Foundation Trust. Steve Roberts, Associate Director of Operations for Older Adult Services, also for the Lincolnshire Partnership Foundation Trust. Yolanda Martin, Associate Director of Communications for the Lincolnshire Partnership Trust. Sue Ann Pang, Head of Mental Health, Learning Disability and Autism Specialised Commissioning for NHS England and NHS Improvement Midlands. Liz Ball, Interim Chief Nursing Officer for the Lincolnshire Clinical Commissioning Group. Cowley Chowdhury, Public Health Consultant, and Simon Evans, Health Scrutiny Officer. We are also expecting others to join later, which will be inclusive of Maz Fosh, Chief Executive of the Lincolnshire Community Health Services, and Tracy Pilcher, Director of Nursing for Lincolnshire Community Health Services. Is there anyone else present who will be participating in the meeting? No, okay, thank you. In which case, I would like to move on to the meeting conduct and ask members of the committee and other participants to type speak in the chat function when you wish to ask a question or make a contribution. Also, I'd like to remind you to please turn off your camera and microphone when not participating. Please keep your questions and contributions succinct and concise, ideally no more than 2 questions per item. And I would also like to stress the importance of treating all our contributors today with respect and to bear in mind our role as constructive scrutineers. Now I'd like to move on to agenda item 3, apologies for absence and replacement members. Trina.
Thank you, Chairman. We've received apologies for absence from Councillor Mrs. Rosemary Caby-Brown, and Councillor Linda Wotton is the replacement member for Councillor Caby-Brown for this meeting only. We have also received an apology for absence from Councillor Sue Woolley, Executive Councillor for NHS Liaison and Community Engagement. Thank you, Chairman.
Once again, welcome, Councillor Mrs. Wotton. It's wonderful to have you with us. We'll move on to agenda item 4, declaration of members' interests. Do members have any interest to declare at this point? No. Should one arise at any point during the meeting, please don't hesitate to raise it at that point. Thank you. In which case, we'll move on to agenda item 5, the minutes from the 17th of June 2020. Can I take a proposer for these being as a correct record, and I plan on taking them on block?
Yeah, I'm happy to propose.
Could I move? I'm happy to second that if that's just been moved, Chairman.
Thank you both. In which case, I will hand over to Trina to call out the names. And once again, it will be for, against, or abstain.
Thank you, Chairman. So, reading everybody's name out, obviously first, Councillor Carl Macy.
For.
Thank you very much. Councillor Chris Brewis.
For.
Councillor Bill Bilton.
For.
Councillor Susanna Barker-Milan.
For.
Councillor Matthew Fido.
For.
Councillor Mrs. Sandra Harrison.
For.
Councillor Rob Kendrick.
For.
Councillor Colin Matthews. Thank you. Councillor Robin Renshaw.
For.
Councillor Glynis Scalesi. Has Councillor Scalesi managed to get in yet?
It doesn't appear so.
Thank you very much. Councillor Angela White.
For.
Councillor Mark Whittington.
For.
Councillor Stephen Woodliff. Councillor Stephen Woodliff. Is he still here?
I'm here.
Yeah.
For.
4. Thank you. Councillor Linda Wotton.
I wasn't present at the last meeting.
Okay, thank you very much. Councillor Ray Wotton.
For.
Okay, so for those members that were present, they're all in agreement, Chairman. It's carried.
Thank you. Those minutes are carried, in which case we'll move on to agenda item 6, the Chairman's announcements. My announcements have been circulated with the agenda and supplementary announcements have been emailed out. The supplementary announcements cover 4 items: Fishtoft Road Dialysis Unit at Boston, 2, the review of renal services, 3, powers for the local authorities during the COVID-19 pandemic, and 4, parking at hospitals. I would also like to ask if the committee would like to send a letter to Dr. Jason Wong congratulating him on his appointment as the Deputy Chief Dental Officer for England. And then can I ask that the Chairman's announcements and supplementary announcements are noted. Also, I have had a request from the presenters of items 7 and 8 to reverse the agenda order of these items. So we will be taking item 8 first. In which case, do I have a proposal for my announcements and send a letter to Dr. Wong?
Yes, you do, Chairman. Thank you. And can I thank you also for the comprehensive nature of your announcements, which I find extremely useful. Thank you very much.
Thank you, Councillor Brewis. Do I have a seconder, please?
Yeah, happy to second, Chairman.
Thank you, Councillor Wotton. Okay, in which case, unless we hear differently, we will take those as noted. If you do have an objection, please raise now. No? Okay, in which case, we'll move straight on to agenda item 8, the Lincolnshire Partnership NHS Foundation Trust's CAMS, pages 25 to 35 of this agenda pack. I'd like to hand over to our presenters, Jane Marshall, Director of Strategy for the Lincolnshire Partnership Foundation Trust, Deborah Hussey, Quality Improvement and Insurance Lead for Specialist Services, and Sue Ann. If you'd like to present for us, please, and we'll take questions at the end. Thank you.
Thank you, Chairman, and good morning, everybody. I'm Jane Marshall, Director of Strategy at Lincolnshire Partnership. I think my colleagues Deb Hussey and Sue-Ann Pang are going to put their cameras on as well and join me in this presentation. Thank you for inviting us to give an update to the committee on 6 months into our new model of care for children and young people's mental health services in Lincolnshire. And I'd just like to start by acknowledging the context in which we're working and to offer condolences to anyone who might have lost loved ones, friends due to COVID-19. It's a difficult context, and we're here celebrating improvements in our services, but we do acknowledge for some people it's been a really difficult time. So we're pleased to present this paper to you, which you requested. So at previous meetings in January, the committee indicated that they were supportive of continuing with our new care model on a pilot basis, but you required further scrutiny of how it was going at the halfway stage. So the data in this report, which hopefully colleagues will have had the opportunity to read, presents our findings in an open, honest way, 5 months in officially to this pilot for a new model of care for children and young people as mental health services. And these are some of the most complex children and young people we have in our county that we care for. And I'd like to say how proud I am of the staff team who've done this work, because they have made real inroads into not only putting a new model of care in place, but also improving the service they deliver. They're very, very committed to doing that well. And I'm sure Deb will pick up some of that in her comments to you as a clinician and a leader in that service division. So if I assume colleagues have had the opportunity to read the paper, what we've tried to do is concentrate the outcomes on your page 26 in that middle block of bullet points there. So within the paper, we've got various data and graphs that hopefully show you that we are making improvements on all of the dimensions that are important to us as a result of this pilot. And they're summarised in those bullet points on your page 26. So if, with your permission, Chairman, I'd just like to briefly run through those, then take questions, if that's okay.
That's absolutely fine. Thank you.
Thank you. So really important to us, given the high risk group of children and young people that we're looking after in this service, is that we work as hard as we can to avoid serious incidents. And serious there, where the committee and the chairman were very concerned that as a result of putting this pilot in place, it was not at the detriment of more children and young people having to travel out of county, out of Lincolnshire for their care. And we are pleased to be able to report that we always planned for up to 2 children and young people out of area at any one time for general adolescent units admissions. And we saw an initial increase in the number of children and young people out of area to 8 when we first had to temporarily close our Ashville unit. But we're pleased to say that in the last 5 months, we have only had 2 children and young people have to go out of area for their care. And that compares well to our previous pattern of children and young people out of area. So previously, in the same time period, April to August, it had been 22 patients going out of area in last year, 2019, 20 in the 7 months prior to that, and 45 during the whole of 2018-19. And that is in the context of us, and we highlight this further on in the bullet point list there for you, that at any one time we've got approximately 2,100 children and young people in our service. So that's 2 people out of area, it's 2 too many, and we are working really, really hard to make sure that we get down to no children and young people out of area. But that's in the context of that broader group of patients that we have, that we see, that we care for. Of the 2 people, and this is the third bullet point, who did have to travel out of area since April, 1 patient travelled to Northampton and 1 patient had to travel to Bristol. But just to give assurance that even if a child is out of area, a child or young person is out of area, our teams reach into those organisations, we make contact, and we are part of active planning to get those children and young people back home as quickly as we possibly can. And I'm sure if there are questions about that, Deb can answer more on how we do that. So our absolute aim is to minimise the number of children and young people who travel out of area for their care, and it must be avoided, unacceptable if they do. So we're pleased to be able to say that at the time of writing this report, we had no children and young people at all out of area for that general adolescent unit group. We've seen significant reductions in the length of time children and young people stay in hospital, and that's a really good quality indicator for us, because what that means is that people aren't in hospital for over long periods of time. So it's a really good quality indicator that we get people into treatment, but we get them out and recovered as quickly as we can, so that people can get home, get back to their normal support mechanisms, to school, etc., back home. Occupied bed days are also reducing, and we've had very positive feedback from patients and carers, and we've actually seen an increase in the numbers of positive pieces of feedback we've had. So I'll stop there, and I'm happy to take questions of detail on anything that we've said, supported by my colleagues who are also on the call. Thank you, Chairman.
Okay, I've got Councillor Whittington first.
Hello, thank you. Thank you very much indeed, Mr. Chairman. Thank you very much indeed, Jane, for the report, which was very, very useful, because I also sit on the Children's Scrutiny Committee, and at our meeting last Friday, we were discussing the impact the closure that Asheville would have on the school that was obviously associated with it. But my questions are really, I've got 2 questions. One is related to out of hours cover, because I see the service is 8:45 in the morning till 7 o'clock at night. So the first question is, what out of hours cover is there? And linked into that is, do we still potentially have respite beds? So if children, young people do need to go in short term, perhaps for stabilisation, would be that question. And the second one is around the nature of the model itself, which obviously is moving from having a large institution like Asheville into doing everything out in the community. And I appreciate the issues you've had with how to do it, partly because of the medical cover, but I get the impression that's kind of forced your hand to kind of adopting a new model of care that's actually better than the previous one. So the first question would be, would there be any plans to move back to that kind of big institutionalized environment, or would you be looking to do more and more, in the schools, in children's homes? Which then leads on to the issue of, it's great that we're doing stuff virtually and via Zoom and things like that, but what sort of support may be there for parents, especially those parents who maybe can't, because of economic issues, can't afford the equipment for a virtual meeting, or may live in an area, because at the moment we've still got a few dodgy areas in Lincolnshire for broadband coverage, how that would work. So those just are a few things that just pop out, which they're not major issues, but I just want a bit of clarity around it. But apart from that, I thought it was a fantastic report. Thank you very much indeed.
Thank you. And I think those are really brilliant questions, so thank you for raising them. If I start at the end and work back upwards, we work with the child and the young person, but we also work with families. And part of our offer is support to parents and wider families to help support their child or young person. We are starting to say digital first. And we've seen the benefits of working online and via telephone and via telemedicine with our patients, but it's not digital only. So if we know that we have an issue that we need to address, like lack of connectivity or lack of equipment because a family might not be able to afford that or have access to it, we absolutely make sure we offer seeing that person or that family face to face, and we don't compromise on that. Medical cover, I think you're absolutely right. We had to take a decision at Ash Villa, which we didn't really want to take because we weren't ready for that. We were planning the pilot, but we had other risks as well. So we had to take that, and we've talked about that with the committee before. Do we have plans to move to a big institution? Our philosophy as an organisation is that if you need an inpatient bed, then absolutely we need to get you access to one. But our vision is to support as many people as we possibly can at home in their communities with their local network around them. And our children and young people's CAMS services operate that all the time. And we know we will have to evaluate the pilot fully. And we know there will need to be a conversation about whether we have an inpatient unit in Lincolnshire. But from our findings so far, we are absolutely convinced that this new model of care is the right one for us, and it fits with our vision and philosophy as an organisation. In terms of respite beds, no, we don't have respite beds. In terms of out-of-hours cover, yes, we do. We have 24/7 cover, even though this paper describes the home treatment team being available between 8:45 in the morning and 7 p.m. In the evening. And we make sure that we have services available at the times that children and young people and family tend to need them. But we do have 24/7 cover. I hope that answers your questions.
Yes, thank you very much, Jane. That's great. And thank you, Mr. Chairman. Thank you.
Thank you. Okay, we have Councillor White next, please.
Thank you. I'd just like to know who can make referrals to this service. I mean, is it just GPs? Is it just GPs or is it?
Thank you, Councillor White. Councillor Brewis.
Thank you, Chairman. And I want to thank Jane for what I think is a very positive and optimistic report. As a former teacher who occasionally still helps people with autism and problems, I just find the idea, much as I love Bristol, I used to take parties of children for a day out in Bristol, and it was really like going on an Apollo moonshot. It was a major undertaking. But the fact that we're now doing them in county where they will, if necessary, have access to people who are near and dear to them, my goodness me, that improve the chances of a successful outcome and improvements. And I really just want to thank you very much for what I think is one of the most positive, always bothered me, this out of county thing. This is one of the most positive reports we've ever had, and I'm extremely grateful to you all.
Thank you, Councillor Bruce. If I might respond, you're absolutely right. Bristol is an unacceptable distance to have to travel for your care. And one of the other things that we're doing is where a child or young person does have to go out of area, and occasionally there will be instances where they do need that care, we are looking to make sure that we only refer people or send people to the East Midlands area. And whilst that is a distance and you know, parents and children have to travel, it's better. So we're working with all of the providers in the East Midlands to make sure we reduce the distance travelled where we possibly can.
Thank you. I just want to build on to Councillor Brewis's question. As you rightly said, I raised this the last time and it was a concern for me. And, you know, a journey of 100 miles away to Northampton and 220 miles away to Bristol, you know, still doesn't sit comfortably with me. Can you tell us really what the transport arrangements are? Because obviously we have high areas of deprivation throughout Lincolnshire. And of course, some families won't be able to afford to go and then visit that child in care. So is there any arrangements in place for that?
I don't know if Deb wants to come in at this point. We absolutely want to support families who don't have access to public transport, and we actively work to make sure we support with rapid transport, secure transport for those clients and families who need it. What I can't say, Chairman, is that for absolutely everybody, we're able to fund families travelling backwards and forwards. But that's one of the main reasons why we need to work hard to reduce that ever happening in the first place. We absolutely share your concerns about the impact on families of having to travel long distances, which is why we're working really, really hard to prevent that at all. Where it does happen, we support where we can.
Okay, thank you. Okay, I have Councillor Mrs Wotton next, please.
Thank you, Chairman. Thank you for the report. I've got a few questions, please. To actually have had the unit out in Sleaford in Rauncy says to me that there was a need, and I understand the closure came about because they couldn't get the right staff from the beginning. And to say that we've got over 2,000 people on CAM's books. Also, I'd like to ask, there will be people that do need to have hospital treatment and need to stay in. So do we have an adolescent unit within Lincolnshire? If not, that says to me that's why we're having to send really severe cases out of county. And is the pilot just home treatment, or do we have sort of beds ready in our area? And that's my questions. Thank you, Chairman.
Thank you, Councillor. So we don't have a mental health inpatient unit for children and young people operating in our county at the moment. That was temporarily closed. That was at Ashvilla. If a child or a young person needs hospital for physical health care, of course they have access to that as any other child would, and there are paediatric services in the acute hospital for physical health care. We absolutely are testing this new model of care because we think it's better, and I think we have to seriously really understand and talk to people about the benefits of a unit, bricks and mortar, as opposed to what we're describing in this paper as, you know, people who are experts in what they do, highly trained in mental health support, going out and being part of communities and working with children, young people and their families in their own homes, in schools. Our 2,100 children have access to community CAM services that are rated outstanding by the Care Quality Commission. And I'm really proud of that because they do a fantastic job. We're very lucky to have what we've got. What we're doing is testing an additional pilot where we are adding on intensive home treatment, as you say, to that already strong community set of services to try something new. And we're really happy to be open about what we do in the future. That's why we're bringing all of these data today on how it's going. We realise it's a big deal that we've temporarily closed an inpatient unit, but the committee's always supported in trying this new way of working. This paper shows it's having positive benefits. We want those to continue, but we do recognise we will need a conversation at some point about what we do and what the future shape of the service looks like.
Thank you, Jane. Thank you, Chairman.
Yeah, thank you, Councillor Wotton. Just adding on though, Jane, from what Councillor Wotton has said, have you in your future plans considered having a building once again for this type of treatment so that they're not going out of area, or they're certainly not going somewhere else in the Midlands? Is this something that will form part of that consultation, or are you not in a position to say that yet?
What I can say is that it's an option. It always has been, but I've been very clear with the committee that it could never be at Ash Villa, the old building, because that building doesn't meet the specification for that type of unit. That specification is set by NHS England, and we have to abide by that, otherwise we're not compliant with the Care Quality Commission standards. So, and then the other factor, Chairman, is the number of children you would need in such a unit for it to be safe. So there is a minimum number of beds that you would need to have a safe unit, and you would have to staff obviously up to that number. And at the moment our modelling shows, and it's proved within this paper, that for general adolescent units we think our demand at any one time is 2 children and young people who need that type of care, and 2, you couldn't have a unit for 2 people. It wouldn't be safe because it'd be too small. So that's the dilemma we've got. But to confirm your question, yes, it is an option to have an inpatient unit in the future. That would need funding, but it is an option.
Thank you, Jane. I think there's clearly could possibly be the need. If you're having some people so far away for this treatment, you may well find that, yes, the demand is only 2 in Lincolnshire, but you could find an influx of patients from other areas that are obviously travelling some distance now. But thank you. Okay, Councillor Kendrick.
Thank you, Chairman. Firstly, just following on from Councillor Whittington, the meeting you referred to is the one I chaired last Friday. And yes, we were interested in having a future report on the success of the pilot. Obviously, clearly from what we've seen in the paper today, it's going well. And, hopefully it'll be a continuing process there. I've got a couple of questions or queries, Chairman. On the serious incidents report, it's good to see, obviously, that's at 0. That's obviously to be welcomed. One thing I was just wondering, though, as regards the reporting system for that, because obviously in inpatient units, incidents are logged and reported by staff. And the final point, I was just wondering if I'm right in thinking that the Trust will be retaining the Ash Villa site and perhaps become a female high dependency unit, which I believe might be the case on that site. Thank you, Chairman.
Thank you for the comments, Councillor Kendrick. If I start with the last question and work back, Deb might want to help me with the first questions about recording serious incidents, but I'll have a go at that one. So Ash Villa is a building that Lincolnshire Partnership Foundation Trust owns. It's our asset. And yes, we are looking at how we use that asset temporarily while it's closed temporarily. And that might be for a different client group. So yes, there are plans for how we use that building on the basis that it's sitting empty, and we know we have females, adults who are out of area in the same way we have to children and young people. So yes, we're looking at options, and if the committee wants us to bring a further paper in due course on that, then really happy to do so. Is the crisis team specific to CAMHS? Yes, it is. It's staffed by CAMHS clinicians. And then the point about incidents, you're absolutely right. Those are more obviously easier to record when you're in an inpatient unit, but my understanding is that staff record them on Datix, which is our risk management and incident reporting system, which you know very well, and that we monitor very carefully this reduction to make sure it's absolutely accurate. I don't know if Deb wants to add to that.
Hello, I'm Deb Hussey. I'm the Quality Improvement and Assurance Lead for Specialist Services. Good morning. Just to reiterate what Jane has said, yes, it is our staff who report on our incident system. What I would say is that the enhanced treatment team have a high level of contact with the child, young person and their families, and we have that regular dialogue. So yes, it would be them or people around them letting us know. But as Jane says, we do take any of that information seriously. It helps inform us about the young person's risk and make sure we have robust management plans in place. And as Jane says, we monitor that very closely.
If a parent has a problem, which is a serious incident, they contact somebody within the trust and they do the dating and while speaking to the parent. Is that right, or have I got that wrong?
I'm very sorry, I didn't quite catch what you said. Apologies.
Sorry, I'll say again. Yeah, I was just wondering then if there is an incident while staff are not present, and as you say, the parent can report that in, and then that is logged on the DATIC system, is it? So it's consistent with the other recording that may take place. Oh, that's great. And Chairman, maybe, yes, as Jane has said, a report on the future of the Ashville site becoming a new unit, I think might be of interest to us later in the year.
Yeah, I've noted that down, Councillor Kendrick. I've also got Sue-Ann who would like to come in at this point as well, please. So, Sue-Ann, would like to come in? Your microphone isn't on, Sue-Ann. Can you take your microphone off mute, please?
Sorry. Good morning, everybody. Just wanted to add from an NHS England perspective as one of the commissioners around children, young people and mental health. From a Tier 4 inpatient perspective, I think we've heard quite a number about options and the wider modelling and picture of need for children and young people around mental health. And what we are keen with the work that Jane and colleagues have been doing around the Ashville pilot is to ensure that we gather additional impact and outcomes from that pilot piece of work so that we can add to the body of evidence and informing what those future commissioning intentions are from a longer term perspective. Colleagues would be aware around the new care models around children, young people for Tier 4 services. And what we are interested from the findings from the Ashville pilot is how do we blend and create more seamless pathways from inpatient to community and not see inpatient facilities, i.e. hospital care, as standalone. So I think the findings and the approach that's being presented from the pilot work is really important. And one of the requirements from NHS England perspective is to ensure that we continue with further engagement with service users and other stakeholders to inform the next stage. So from our perspective, we would be seeking additional extension to the pilot, just to extend it a little bit longer, because obviously at the moment, as Jane has mentioned, it's up to October 2020. So we're taking an internal paper through NHS England governance to see if we could extend some of that support from October to March 2021, just so that we increase the duration and learning from the pilot, so that going forward the new care models can begin to build and factor that in as part of the wider commissioning intentions and a need for the area, not just the area of Lincolnshire, but also for the East Midlands. Hopefully that makes sense, that there's a bit of assurance that whilst this is a pilot, it does fit into a wider, longer term plan.
Thank you, that's helpful. I have Councillor Woodliff, you've asked a question on the meetings chat. Would you like to ask that question in person now, please? Councillor Woodliff, are you there?
Can you hear me?
We can hear you.
Oh, thank you, Chairman. Right, I put the two questions up on the screen so that people know. You can read them yourself, I think. Is that correct? How certain are you that all those children who require special care are being identified by the GP services? Because obviously, if the children are not being picked up, they're not going to receive the care. So it's the first line, isn't it? Who's spotting who needs this special care? Because if you're not being spotted, then it's not going to happen. And the Second question, which is also I've given, is what assistance is being given to those who pass through the 18-year-old threshold? Because I understand that some families have been dropped at that point, straight in the muck, if you like. So help up to 18, bang, it's gone. So I want to know what assistance is given to those who still need care but have passed through the 18-year-old threshold. And they're my two questions. Thank you, Chairman.
Thank you, Councillor Woodliffe.
Thank you. So if I answer the second one first, and again, Deb may want to come in, we absolutely make sure we plan for what we call the transition of someone who reaches their 18th birthday and transfers into our adult services. And we do that through, very simply, adult teams speaking with the CAMS teams, the Children and Young People's team, in the run-up to the 18th birthday, so that there is a plan for that transition into the new service. It is an area that we know we always have to pay attention to and to work hard to get right. But we are increasingly integrating that threshold, as you describe it, Councillor Woodliffe, between the two. I don't know if Deb wants to add anything to that.
Just to reiterate what Jane has said, we have a very clear process of managing that transition for a young person as they turn 18, and we would start working with our colleagues in adult services up to 6 months before the young person reaches 18. It's very much done in collaboration with the young person, and if they want their families involved as well, we have a clear...
First question about our GP colleagues identifying children and young people with mental health problems. We have excellent GPs in our county, and they are very, very good at identifying and referring in clients, patients that they're worried about. What we have seen during COVID is a reduction in the number of CAMS referrals. That's steadily starting to get back to normal, but we are concerned about that reduction because we believe there may be some children and young people who, because of lockdown, have not been referred through to our services. So we're actively looking at what we do about that without building a big waiting list. So really concerned, and thank you for raising it. But our GP colleagues are very, very good overall at identifying patients who need our services.
Thank you. Is that okay, Councillor Woodliffe? I take it as is.
Chairman?
Yes.
Sorry, can you hear me?
I can hear you now.
I will need to write to Miss Marshall about this because I'm not completely happy with this. Based upon some of the evidence that's been passed to me, there is a serious issue, particularly with boys who travel through the 18-year-old threshold. Okay, and we understand that boys' brains don't develop properly until the age of 25 or thereabouts. I think there's a delay there. So there is an issue here. So I will write to you.
Thank you. I'd welcome that letter, and we'll be able to share with you some of our protocols and processes for a bit of a confirm and challenge on that. Really happy to do that piece of work with you.
Thank you. It would be useful for all of the committee perhaps to receive that information as well. I think it'll be of interest.
Thank you.
Just building on really from what you've just alluded to, how are you going to manage any surge in demand for CAMS arising from the effects of COVID-19?
We're planning that actively as part of our recovery work. So we've looked at various options, Chairman, about not building a waiting list in the first place, because we think that would be more difficult, that would be a bigger problem. But actively working with our primary care colleagues, with GPs, with schools, to identify those people who need our services. We've put lots of messages out, we're open, come, if you need a service, come, and we're actively doing that on a daily basis, weekly basis, to make sure that there aren't children and young people out there who need us, who aren't getting access to us.
Okay, thank you for that, Jane. In which case, we've got Councillor Whittington. You'd like to come back in with a follow-up question. Then I've got a couple of questions and I'm closing the debate down and I'll move to a proposal. Councillor Whittington.
Thank you very much indeed, Mr. Chair, and thank you for allowing me to come back. Just a couple of things that have come to my mind. many years ago, I worked for the East Midlands Specialist Commissioning Group in adult mental health forensic mental health commissioning, and I know the particular marking model for adult forensic was a mixed model between NHS provision and independent sector and third sector provision. I was just wondering what the model is for the out of county placements that our young people go into. Are they into NHS units or are they into independent sector or third sector, if that is the model that's being used there? And I also know, I mean, I'm going back over a decade, and the unit costs for some of these units are, I know then, quite extensive. And I wouldn't have imagined they've got any cheaper over the past decade. I imagine they've probably increased. And obviously I don't want you to share any confidential information, but I guess the unit costs of placing out of county are pretty high. But in terms of picking up on the point that's been made about a unit back in Lincolnshire, and that having two young people is not sufficient cohort, because I seem to remember that when we were wanting to commission new wards, depending on the type of service, you're looking at least 12, 16 in a unit, possibly 24 and more, but kind of in blocks of 10 and 12. What would be your kind of, what sort of cohort would you need in numbers terms before an inpatient unit could be provided? Because I accept the fact that with two, and I accept your point, there's just no way you can provide a safe service. But what would be the sort of cohort level you'd be looking at? Thank you, Mr. Chairman.
So in answer to the number of people in a unit, it is around about 12, as you say. I think there are some different views, but from a safety perspective, it's 12. And there were 13 beds at Ashville, just to give you some context. The first question, we work for CAMS, it's a mix of independent sector providers and NHS ones that provide care at Tier 4 in the region of the East Midlands, and we work very, very closely with our colleagues in the independent sector as part of planning and delivering the services that we do. There is no independent sector provision for CAMS in Lincolnshire.
Thank you very much.
Thank you.
Jane,
a couple of questions, Jane, please. On page 32, it includes examples of the feedback, which is positive overall. Are there any lessons to be learned from that feedback?
Sorry, please, could you repeat that, Chairman?
Yeah, no problem. Yeah, page 32 includes examples of the feedback, which is positive overall. Are there any lessons to be learned from the feedback, though?
I think there always are lessons to be learned. I think we constantly do that. And I think post-COVID, we've got to get even better at it. And we are trying to do that. So, for example, Chairman, we've asked our Health Watch colleagues to come and present to us at our recovery cell this Thursday on some of the feedback they've got from patients experiencing the NHS in the system. So yes, we've got some there. We've seen a positive increase in expressions of satisfaction. We're going to continue working on that and invite as much feedback as we can into our deliberations. And I think, if we do go to any kind of engagement or public consultation on this model, we need to do even more of that as well. So we'll be doing everything we're doing now, plus, and then hopefully some more as we go through to the end of the pilot.
Okay, thank you, which leads on nicely to my next question. I assume NHS England and NHS Improvement will be leading on the engagement and consultation. What form do you expect the consultation to take?
Yes, it's an NHS England lead. We'll be doing that in partnership with our colleagues in NHS England. And the model that I'd be recommending, Chairman, subject to what my colleagues at NHS EI say, is one of, the process we followed when we talked about our configuration of learning disability services, where we have focus groups in as many places around the county as we can, where we invite absolute carers, patient feedback, stakeholder feedback, that we bring that unabridged forward in our considerations for what people are actually saying. It worked really well for our learning disability service. So I would propose something similar, obviously subject to what you direct us to do as well as a committee. But yeah, an open, honest conversation about what we want to do will be my approach.
Okay, thank you. So when should the committee look to consider scheduling an item on its work programme in regards to the consultation? Are we looking sort of 14th of October or 11th of November to be adding it on?
I think, if, with your permission, if we brought a paper which did a full evaluation to the end of October in November to you, and then have a conversation, possibly then informed by what Sue-Ann was saying about possibly extending the pilot to the end of March, but then planning what we're going to do on engagement and consultation, that would help us.
That's great, thank you. Okay, thank you. So in which case, I would like to propose that we commend LPFT on the positive feedback on the interim home treatment team service, and to programme an item for the committee in November on the consultation and whether.
Thank you, Chairman. Okay, so if members can indicate whether they're for, against or abstain against this. So Councillor Macy.
For.
Councillor Chris Brewis.
For.
Councillor Bill Bilton.
For.
So Susanna Barker-Milan.
For.
Councillor Matthew Fido. Councillor Fido. Councillor Mrs. Sandra Harrison.
For.
Councillor Rob Kendrick.
For.
Councillor Colin Matthews. Can you all just turn your microphones off a minute? Right. Councillor Robin Renshaw.
For.
Councillor Glynis Scalesi made it in or not? I don't think she has, she?
Trina, it's Simon. Councillor Scalesi is recording apologies. Thank you.
Right. Thank you. Councillor Angela White.
For.
Councillor Mark Whittington.
For.
Councillor Woodliff.
For.
Councillor Linda Wootton.
For.
Councillor Ray Wootton.
For.
Can I go back? Is Councillor Matthew Fido there? As he'd indicated, he's left the meeting. Councillor Fido? No. Okay, but that's from those members that are present, it's unanimous then, Chairman.
Thank you, Trina, that's helpful. And thank you to our presenters on that item. I know that I believe Sue-Ann is leaving us for this next part, so thank you. In which case, we'll move on to agenda item 7, pages 17 to 23 of the agenda pack. I'd like to welcome once again Jane Marshall and Deborah Hussey. If I can hand over to you for the presentation, that would be wonderful. Thank you.
Thank you, Chairman. This report at agenda item 7 was requested by the Chairman for Lincolnshire Partnership to explain what we've been doing in response to the COVID-19 pandemic, which has been impactful, as we all know, but this paper sets out from page 17 what we've been able to do, to support Lincolnshire and help to manage the pandemic as a small provider in that mix, but also see the opportunities that such a pandemic brings in terms of changing the way we deliver services, working in different ways, bringing in new ideas to improve our services. And you'll see on page 18 and 19 in the boxes there, some of the changes that we've been able to put in place temporarily as we've delivered services in different ways. And different ways includes obviously ensuring social distancing, that patients are safe, that carers are safe, that families are safe. And we mention all of those services at we've got older adult services at the top of page 19, where we've been able to really think about in making some improvements. We have done a lot of work on providing services online and digitally and via telemedicine. That's worked really well for us. Our staff have enjoyed working in that way, and we've actually seen that through telephone contacts and online and digital contacts, we've seen more patients. So there was something like 3,000 more appointments offered in the month of April, working in a different way. So we don't want to lose some of those benefits. Our staff are saying and are getting back to seeing patients face to face, but we want to continue the conversation about how much of our work we can do digitally and online. And we've, just for assurance, we've always seen, even in lockdown, any urgent patient face to face. So we've only ever asked routine patients to be seen online or via digital means or telephone, always face to face if you're absolutely an urgent patient. So pages 18 and 19 list out some of the changes that we've made. And page 20 gives assurance that despite the fact that we've been in a period of lockdown, we at the top there, the top graph shows that 71.7% of our patients have had a direct contact recorded in the last 12 weeks. And that compares really, really well to 46% for other mental health organisations nationally. So we've been able to make sure that the patients who are in our care have had contact with us. The second graph there highlights the issue that I spoke about with relation to Agenda Item 8, where we have seen for our child and adolescent mental health service a significant drop in all access points. So those are all our referral points coming in. And as I said previously, we're monitoring that very, very closely. And you'll see for May and June, those numbers are starting to rebuild. We saw that dip in April that we were concerned about. In terms of where those patients who would have been referred in by their GPs, what we've seen in graph 3 there is those people coming instead through accident and emergency and crisis type referrals. So you'll see that squiggly bit on the end of that upward line is a significant all-cause variation in that level of activity. So we think that patients have come in through A&E and crisis rather than necessarily going to see their GP. But again, we are monitoring that very, very closely. At the top of page 21, we wanted to include here, and I'm sorry that these aren't very large graphs, we wanted to show the increase, the reduction in face-to-face contacts for routine patients, but the increase in telephone contacts and telemedicine contacts, so that the total line shows that overall we were able to see slightly more people than we would ordinarily see. And as a result, and I'll come on to waiting times later on in this paper, we haven't seen a significant reduction or increase in the length of time people are waiting against the 18-week standard that we monitor. At the bottom of page 1, we've seen a positive reduction in the number of our patients who do not attend their appointments, so that's good news. A significant and sustained drop in did not attend, which is important because obviously we need to use those appointment slots and patients need access if at all possible. And the top of page 22, we look there at our overall out of area bed days. So we have seen an increase from June in the number of bed days occupied by are patients who are out of area, but that's despite us having to take out 8 acute and 2 psychiatric intensive care unit beds because of the increased social distancing we've had to adhere to on our wards for infection prevention and control. So again, we've not seen a detrimental impact or an increase in the number of people who've gone out of area, all ages, adults, for their care. And at the bottom of 22, I've got our waiting time. So we did see a reduction in February in our achievement against the 18-week standard, which we are required to achieve 95%. We dipped below 90% in February, but you'll see that we've gradually increased our performance back to the level that we want to have, so that patients aren't waiting longer than they should. And finally, on that page, we've worked, as others have, really hard to make sure that we are supporting our staff who identify as Black, Asian or minority ethnic colleagues. And we've obviously all noticed the detrimental impact on those groups of people of COVID-19. So we've put an enhanced staff wellbeing service in for all of our staff, and we've done specific pieces of work around our BAME staff, Black, Asian, minority ethnic staff. And we've got our medical director, Ananta Dave, who's leading a piece of work nationally on BAME staff with the Royal College of Psychiatry, which has been really good. But a really strong staff wellbeing offer and emotional support to help those staff who are dealing with patients suffering with COVID-19. We're really proud of that, and we've extended that across Lincolnshire to the NHS and other organisations, so that their staff have access to that offer as well. So in conclusion, we've played our part. We've changed service delivery to meet patient need during lockdown. We've seen improvements in the way we do things, which we don't want to lose, but we want to talk about that. So we've invited feedback from staff and patients on how it feels for them. We've ensured we've kept on top of our key targets to make sure that we are compliant and therefore delivering quality services. We've worked hard to support our staff during this difficult time, and BAME staff. We are fully set up. We've been planning for our recovery, even though we're still obviously managing a level 4 incident from May time. So we are looking at moving to a new normal way of working through our recovery planning. And we've done a piece of work questionnaire to gauge staff and patient experiences of work during COVID-19. We've had 200 of our staff plus respond to that survey. Thank you, Chairman. Happy to take questions.
Thank you, Jane. The first question is Councillor Whittington.
Hello, Mr. Chairman.
I can hear you. Thank you, Councillor Whittington.
Thank you, Mr. Chair. Thanks, Jane. Again, thanks, Jane, for the report. This is at several points in the report you've used the phrase new normal in inverted commas, and I think an awful lot of organisations in the public sector and also in the private sector, in fact, are looking to potentially what that new normal may look at. And it's interesting to see that you're looking to see going forward. I get the impression from what you're saying, you see more of a mixed model in the future, where there will still be the face-to-face stuff going on, but you potentially make an increasing reliance upon, if you can have virtual meetings and virtual stuff, you'll do that. Again, it's the same question as I asked about the previous one, just about the reassurance for those people who, for economic issues or poor broadband, or potentially with this, so some of these cohorts, elderly people who may have dementia and stuff like that, or issues that may affect their ability to operate, to hold virtual meetings, what support potentially is there, obviously, to help them. I appreciate that at the moment your targets are going to be all over the place, because I think everybody's performance targets at the moment in any organisation are a bit out of the window until we get back. But in terms of activity, I guess it's too early for you, because I notice your activity is starting to come back up again. But I guess it's maybe far too early for you to know what level that's going to stabilise at. It may be higher than it was before, it may be lower, it may be the same, and I guess at the moment you don't know. So I'm just wondering, potentially, when you think you might have established what that new baseline potentially could be, and at that point, if potentially, and again, maybe the committee at a future point could receive an update as to what this new normal looks like, what your new model's going to be, what you think your new baseline of activity is. So just a few questions around that. But I appreciate at the moment that there's a certain amount, and any organisation at the moment, of a little bit of the old crystal ball looking at the moment, because we're not entirely sure. Thank you, Mr. Chairman.
Thank you for those questions. We have modelled through what we expect the return to normal to be, and we've also modelled through what we think might happen with some options about those patients who, from a mental health point of view, might be affected by COVID-19, who will come through later on to access us, who may come later on. And we've absolutely modelled that through already as part of our recovery work. You're absolutely right, it's not an exact science, but we are anticipating that we will see, probably over an extended period of time, possibly up to 10 years, people coming through to us from a mental health point of view who weren't patients of ours previously, but will be because of the impact of COVID-19. So we're actively planning for that, and modelling through the resources that we'll need to have in place to deal with that demand. The other thing we're doing is we're working really hard through some work that Brendan Hayes is leading in our recovery planning for mental health in Lincolnshire on what we're calling a universal offer of support. So the wraparound care that we have within local communities, within market towns, to help support people with their emotional well-being and mental health at a mild to moderate sort of level. So if the committee wanted to receive feedback on that at a future date on our universal offer, we'd really welcome being able to come and explain that, because if we get that right, we develop communities with a level of resilience to be able to care for themselves, as well as having the statutory services available for them.
That will be useful. Anything further?
Yes, just one thing. Something that Jane said about increased social distancing on inpatient wards. Sorry, that's my phone going. Increased social distancing on inpatient wards. Presumably, that's going to have a big impact on costs, because if say take a 12-person ward, if that then becomes a 6-patient ward, say, so you can put in social distancing. I'm just plucking figures here. Potentially, there will be patients who've been displaced from there who need to go elsewhere, and I'm just wondering where they would go. And I guess if it is out of county, potentially it's going to be a lot of pressure, because everybody in the rest of the country is going to be in the same position if they've introduced social distancing on their inpatient wards. How the market is going to potentially deal with this, because at the moment it's a short-term thing, but we don't know what's going to happen with COVID, and the social distancing in hospitals might be a thing of the future. That we have to accept the fact that each ward will have less capacity than previously. Thank you, Mr. Chair.
Right. That's right. So a very simple example for you. We had, as we've said in this paper, to take 10 acute adult mental health beds out because of social distancing requirements on our wards. If we'd had those 10 beds available to us, we would have been able to bring 10 patients back from out of area. But from an infection prevention and control point of view, and to keep our staff and patients safe, we can't do that yet. So you're absolutely right, there is a consequence to that social distancing arrangements that we've had to have as part of our wards.
If I can sort of go on from what Councillor Whittington said, in which case, I mean, on page 19, you have mentioned the mothballed and patient unit, which is currently being explored as a temporary unit. Where is this, and when will a decision be made in regards to this?
Yes, that refers to Ash Villa. So we use the building of Ash Villa during COVID as a temporary accommodation unit, so to help us step our patients through, because their onward progression into housing of their own was affected by lockdown, so that couldn't happen. So we created an accommodation unit at Ash Villa temporarily. The future plans for Ash Villa as a high dependency unit or an adult ward are different to that, Chairman. So they're the next iteration of the plans. That mothballed unit will close as an accommodation centre, and we'll then think about future use separately. I hope that makes sense.
It does. Thank you, Jane.
Human beings, and I do hear, listening to local residents, that they're getting by, and if they're getting by, then they appear to be forgotten, and then that affects not only the physical health but the mental health, and I think we mustn't lose fact of that. And finally, I just want to make a point about the pandemic has been estimated to be likely to cause an extra 35,000 extra deaths due to cancer in the UK, and that is not acceptable, and that's mainly due to waiting times being missed and aggregated, and all sorts of reasons why. Some are valid, some are less valid. But I think, that we have to move forward and be positive, and not accept that 35,000 extra cancer deaths due to the pandemic is acceptable, because it's, to me, they're all human beings. Thank you, Chairman.
Thank you, Councillor Renshaw. Okay, Dr. Woodkey.
Sorry, I missed your response, Chairman, because I missed your response because I muted. I pressed the wrong icon. If you'd like to say it again.
That's fine. Jane, would you like to respond?
I couldn't agree more. We're absolutely all human beings, and I think part of our response through recovery and how we work together in Lincolnshire around those patients, those people who have been affected, is really important. So as a mental health provider, we don't provide care for people with cancer, but we can work with our colleagues in the acute trust to think about how we maybe support with the impact on their mental health as the acute trust deals with their physical health and their cancer treatment. But you're absolutely right, there are absolutely devastating consequences of the pandemic, and we all need to work together to address those in the best way we can.
Okay, thank you. You happy with that, Councillor Renshaw?
Yes, I am. Thank you.
Thank you. Dr. Woodkey, you'd like to come in, please?
Thank you, Chairman. Brian Woodkey, Health Watch Lincolnshire. Jane actually did refer to what I'm going to say, and I think it's probably accepted by everyone that there is an enormous increase in mental health problems following COVID, and we in Health Watch are getting quite a mushrooming of reports of people in distress. These people may be people who've been under isolation over a period of 15, 16 weeks at times, other people with pre-existing physical illness and pre-existing mental illness. And in particular, I think it's anxiety and depression and worry about how things are going to get back to normal, if they ever do, in the foreseeable future. And that I think is bound to put a pressure not only on primary care and community care, but on yourselves. And so this isn't in no way a criticism, but it's really to draw awareness to the fact that I think there is going to be an enormous increase on demand for support and help. And I'm sure you are already aware of this, and you've said you are, but I would wonder how actually you are going to address this, because I don't think just the figures looking on your graphs really answer the problem. So just could you comment on that, Jane, because I think it's something that's going to affect us all for a long time.
I agree totally with you. So we've done several things, Brian. We've invited our Health Watch colleagues to feed back to us on patient experience, people's experience during the epidemic. That's happening tomorrow. We will feed that feedback into our recovery planning. As part of our recovery planning, we've modelled through the number of people with a mental health condition that we expect to come through our services, both post-COVID, but then as a result of the impact of COVID. And you're absolutely right. We are expecting that to be a significantly high number of people coming through. So the third thing we're actively doing is, again, through the recovery process, recovery restoration, we are looking at different ways that we can, A, spot early that people are unwell, and B, provide a service early, not necessarily through LPFT, but working in partnership with others. And that's where the universal offer comes in that I spoke about. So we're working with a GP down in Stamford who's actively planning with us, what our response can be, so that we're not overwhelmed. We plan for that increase of people coming through. There are no easy answers. But we're actively making sure we're trying to put the right plans in place to deal with that. And that is work in progress, and it will continue for the next 18 months, 2 years, 3 years, possibly even more. But I just repeat the point, we all need to work together on it, because if there are people out there who are suffering, they need a service, they need a response.
Thank you.
Thank you.
Would you like to come back at all, or is that?
No, that's fine. Thank you, Jane.
Okay, thank you. I have Councillor Kendrick next, please.
Thank you, Chairman. Yes, it's been a very difficult time, I'm sure, for everyone in LPFT, and I was greatly saddened to hear the loss of one of the medical staff reported a little while ago. I mean, that's very sad. I can't say I knew very well. I think we're on nodding acquaintance in the corridors, and I'm very sad to hear that. On that line of support for staff, I was just wondering sort of how testing went for staff of COVID-19, how that progressed, and whether you had a high number of staff who had to isolate. Hopefully not. And my second question is, unsurprisingly, I was interested in the point on community volunteering and the offer to have a report on that. I'm sure that would be interesting, having myself and my previous existence set up support groups in local communities in places like Louth and elsewhere and Spalding to support people at a low level. So I'd be interested in that. But one of the positive things I suppose you could say that's come out of this is some new ways of working, which everyone in the public sector and private sector has come up with now. And the DNA rate dropping dramatically. I mean, that must be welcome news. But if I could just have a comment on those, that'd be great. Thanks very much, Chairman.
Thank you, Councillor Kendrick. So at the height of the pandemic, which was probably April, May time, of our 2,100 staff in LPFT, we had about 70, 80 people who were either self-isolating and shielding. But that number has obviously come right down. In terms of testing, we had really good uptake by our staff. And our Director of Nursing, AHPs and Quality, Anita Lewin, worked really hard to make sure that that was available and that staff were taking that offer up. We've had really good processes in place for protecting staff and giving them access to testing. Anita's been brilliant, as have other leaders, and Steve may comment later on, Steve Roberts. Community volunteering, absolutely. I'm seeing that we need, as that community resilience includes community volunteers. That has to come through the universal offer work that we're doing. And I really look forward to some of that, because I think we've seen some really good examples, haven't we, of people working in different ways in communities that we can't lose. And that links to my final comment, really. There are so many good things that have happened positively as a result of this. We can't waste. No, never waste a good crisis. Is that what they say?
Thank you very much. Thank you.
Okay, thank you, Jane. I think that's all questions we have at the moment in time. We're going to move to a proposal, and that is to record the committee's gratitude to all the staff of the Lincolnshire Partnership NHS Foundation Trust on its response to COVID-19, and to request an update on the universal offer.
So Susanna Barker-Milan.
4.
Councillor Matthew Fido, is he back at all?
4.
Thank you. Councillor Mrs Sandra Harrison.
4.
Thank you. Councillor Rob Kendrick.
4.
Colin Matthews, I think.
4.
Thank you. Councillor Robin Renshaw.
4.
Councillor Angela White.
4.
Councillor Mark Whittington.
4.
Councillor Stephen Woodliff.
4.
Thank you. Councillor Linda Wotton.
4.
Councillor Ray Wotton.
4.
Unanimous then, Chairman.
Thank you. That's carried, in which case. Thanks very much, Jane. We'll now move on to your next item, agenda item 9, Lincolnshire Partnership Foundations Trust Older Adult Home Treatment Services. You can find this in pages 37 to 40 of the agenda pack. And I'd like to welcome once again Jane Marshall, Paul Hussey, and Steve Roberts. And I'll hand over to you for the presentation. Thank you.
Thank you, Chairman. And I'm going to ask my colleague Steve Roberts to take us through this great piece of work, because he's the leader of all of this and it's his baby. And I'm sure you're sick of the sound of my voice. So if I could invite Steve to take us through the paper. Thank you.
Yeah. Good morning, everybody. Yes, certainly. Thank you for inviting me along to quickly talk through this. As Jane said, you've seen the paper, but what I'll do is just quickly take you through the highlights and maybe a slight little bit more context, and then open up for questions after that. So this is for the home treatment service for older adults with mental health issues, and not those with dementia, for mental health specifically. This has been running now for 22 months. This is actually our 3rd review of the service, and happy to say all 3 reviews have been incredibly positive. And basically the service replaced 18 inpatient beds with a alternative community offer of intensive 7-day-a-week support. Really important there that this is the first service that's actually provided older adults with that 7-day-a-week service as a viable alternative. So that's been a massive step forward, and also provided a continuous care pathway for older adults as well between the CMHTs and inpatient care. So you had CMHTs, so the community mental health teams, then step up to intensive home treatment support, inpatient wards only for those who really needed to go in, and then step down to home treatment as well as required. So the outcomes at 22 months, I think it's fair to say, have actually exceeded our expectations. So our work going into this indicated that in any one time we had about 35% of patients in our inpatient wards, if there was an alternative high intensity input offer, didn't require to be there and could have been cared for within the community. Happy to say that figures actually exceeded that number and has been in excess of 50%. And really, this is evidenced through continuous outcomes at review at 6 months, 9 months and 20 months, which showed a 93% admission avoidance. So to put that into context, of 394 patients who previously would have been considered and in all probability would have escalated to inpatient care, 93% of those actually didn't go into hospital. So I think only 27 out of 394 patients ended up going into inpatient care from that cohort, which is an absolutely massive outcome. So admission avoidance has been essential, and within the context of the discussions that have just happened, especially during this pandemic, when the focus has been absolutely to keep people in the communities, again, the dividends that the model has paid during that has been tenfold. So as well as the admission avoidance, to run through very quickly, people receiving home treatment, that their duration of care is 55% shorter than those who previously went into inpatient care. So their care episode is shorter. There's been less medications used, which is incredibly important in older adults, significantly less clinical incidents, but importantly, improved wellbeing outcomes. So over 97% of individuals using the service have evidenced the elevation in general well-being, which is patient reported, that we would expect to see from the level of service-wise to enable them to step back down to a lower level of care. So incredibly good outcomes. Really, I think important and in some ways counterintuitive is that what the model has done is by removing beds from the system has enabled greater access to beds, which sounds a bit counterintuitive, but by halving our number of beds and providing the home treatment team, not only have we had the positive outcomes for the patients in receipt of direct care, but for the remaining inpatient beds, we've seen a number of huge benefits. So we've seen a 39% reduction in the length of stay for those patients who do go into the remaining beds. We've seen a reduced bed occupancy. And overall, what this means is that actually the access to beds, even though there are fewer, has increased significantly. So those patients who are the most acute, who absolutely need inpatient care, now have more rapid access to inpatient care, and their inpatient care stays are shorter as a consequence to the ward being more focused on that highest end acuity. And not to lose sight of the bigger picture as well, and in terms of outcomes for out of area, again, even though the bed stock was halved, that out of area usage has reduced from what was already low levels to incredibly low levels. In fact, I don't think we have had a mental health related older adult out of area this year, and certainly for most of the 22 months, the figures have been incredibly low. What we've also seen is for those who do go out of area, because of having the 7-day-a-week service, that repatriation is also significantly quicker for those individuals that do have to leave the county. And sometimes individuals do, because there's certain types of care that we don't provide in county, certainly for the more acute PQ level type need for older adults that very rarely is required. So in summary, at 3 review points, service continues to deliver above and beyond what the expectations were. The primary thinking behind the service was that we were admitting certain patients unnecessarily, simply because there wasn't the level of service required to support their needs. The provision of the service has shown that, in fact, a huge cohort of patients and people can be cared for at home in their own locality with no travel, with intensive input that meets their need, and that the outcomes thus far have been incredibly positive. So I'll open up if there are any questions. Happy to take those in partnership with Jane.
Thank you, Steve. Okay, my first question is from Councillor Brewis, please.
Thank you, Chairman. I think the report thus far is optimistic, but I mean, speaking as I do remotely to quite a lot of people, including elderly people, their reluctance at the moment with the confusing instructions and news coming out during our current crisis to be involved in any way with anything suggests to me that the number of people who are isolated during COVID, if and when it comes to an end, nobody knows when that's going to be. I think it'll be over a year, it might be less, I don't know. Do we not fear there might be a tsunami of needs suddenly come over the horizon at very short notice? That's my real worry.
Obviously, reflecting on previous discussions, obviously what we can't foresee is what the level of need is. We are anticipating greater need. I suppose what I would say is that obviously we were running this service for a considerable period prior to the onset of the current pandemic, and certainly the service's outcomes, I said, exceeded expectations. I think the positive thing is the service isn't standalone. What it's enabled us to do is, as I sort of touched on earlier, is set up a continuous care pathway. So what I mean by that is that to support the higher level of need. So one of the benefits and what this service has enabled us to do is actually instill a single point of decision making across the entire pathway. So what I mean by that is unlike some services where home treatment, crisis wards, community services all have separate line managements and medics, because this is a single aligned, single decision making process, that we don't hit up against any of those points or where there's resistance, and so we can actually make the decisions across every point of the pathway to flex and contract that. Now, obviously, what I can't say is that we will absolutely have capacity, because we don't at this point know what demand is. But what I can say with assurance is over the 22 months of use thus far, that we have continued to deliver at the level of service need required, and that we have also, whilst not a topic of discussion here, but within the services, we've made other major changes in response to COVID very rapidly in order to change to the demand, and we have a degree of confidence in our ability to continue to do that.
Thank you very much. I think your adaptability and flexibility gives me more confidence. Thank you.
Thank you. Thank you, Councillor Brewis. Councillor Whittington.
Thank you very much indeed, Mr. Chairman, and thank you for the report. It certainly is looks like the initial stage is that it's a promising situation. I am noting a trend here over some of the papers, that this move away from large institutional units towards caring for people at home, which I think is to be welcome, because certainly I think most people would, if given the option, would prefer to receive treatment in their own homes and stay in their own home environment. I'm just wondering, obviously, potentially a great number of these of the cohorts of these elderly people could potentially be in receipt of adult social care. I'm thinking in terms of home care. I'm just wondering what level of cooperation or joint working that you would potentially have with home care providers, because potentially, you know, they are going to elderly people's houses maybe 3, sometimes 4 times a day, and I'm just wondering what links you've got there, because obviously they might spot something, or with a little bit of training they may spot an issue and be able to refer it back to you. So just a little bit around that would be useful. Thank you, Mr. Chairman.
Yeah, absolutely. I think that the networking and working cross services is absolutely essential. As you're quite right, that these individuals often have multiple care providers or individuals going and supporting, and listening to and getting feedback from them is absolutely essential. One of the key things that the home treatment team has done is actually link in with all of those organisations. Obviously, that's an ongoing process, as we're seeing with neighbourhood teams as well. But it is about having that time as a specialised focused service to actually liaise across services to provide that coordinated, intensive, like I said, across numerous, because as you're indicating, that usually the needs are not just mental health, it's often physical health care needs, there's social needs in there, as well as their emotional related needs that we manage. So it's certainly not a provision that is done in isolation. Most of these patients as well are also on what we call CPA, on the care programme approach, so are usually multi-organisational. And in that sense, that reviews of their care also include all of the organisations that are involved in any individual case. I think that the networks are also developing further, and certainly there's a lot more work to be done. But when you look at the work that is focusing at the primary care mental health level and the neighbourhood team level development, and trying to develop further the sharing of information across systems as well, so that we can have sight of multiple service input, which is certainly going to improve further our ability to be aware of information provided to others, whether that be district nurses, physiotherapists, social care, home care. So there's certainly more work to do in that scope. But you're right, it's absolutely pivotal, and it has been, I think, one of the key areas of success of the team, that they have been able to develop and foster those relationships in order to make sure that the plans and care they put in place is robust and coordinated, and also that we're not duplicating. Last thing we need, given the resources that all of us have and the struggles we have, is to be repeating work done by others. So just as a quick example, we've done some work with EMAS as well, in terms of supporting them in terms of early response to avoid conveyance to hospital that isn't necessary if it's more of an intensive home input that's required. So it certainly is about making these links across all of the providers, and it's work that is underway. It's showing green shoots, but certainly isn't finished at this point.
Okay, thank you.
Thank you.
Okay.
Thank you, Richie. Thank you. Thanks. Thank you.
Thank you, Councillor Whittington. Councillor White, would you like to come in now, please?
Yes, I'd just like to ask if you've seen any positive effects of COVID-19. For example, in Netlham, volunteers went round everybody in the village offering their services. They could order hot meals, somebody could do their shopping, get prescriptions. Similarly, the Wellbeing Service have delivered hundreds of food parcels. And it's not just the service, it's the fact that there's increased social contact for vulnerable and isolated people. Thank you.
Yes, I would say yes, we have. And I think for the older adults, it's been particularly necessary. So just reflecting back on some earlier discussions, so that yes, there's a lot of positive news in reductions of DNAs, but what we've also seen is that during this period, a lot of older adults in particular declined their visits because of the concerns about their personal safety, and even individuals coming into their homes or travelling out. So the risk of social isolation has been considerable, and I don't think we've seen the full effect of that. I think we will certainly start to see that. But you're right, what we've also seen is that increased sense of community, which sadly, when I say sadly, we see at such times of crisis. I only say sadly because it's a pity that we can't perpetuate that for much longer than just during crisis. But it is about, as James touched on, I think everyone else, and trying to hold on to those new sort of links that we've made, those new ways of working, not losing that, trying to foster them. And I think this links into the discussions Jane was touching on about the universal offer, and how we then free up our services to focus on those real complex issues, so that we're not picking up levels of support that actually can be provided, probably in a far better and more personalised way by others within the local community. And I think that along with new ways of working, one of the key things that changes we're trying to make over the last few years, and still is trying to move away from being a little less paternal, and certainly a bit more to doing with and enabling people to, rather than just doing for. And I think that's one of the things that home treatment really enables, because unlike removing somebody to a ward where invariably things are done to and for, that in their own community, we can work with the resources around them to set up those networks and support them and enable them to sustain those once we withdraw our service. So, yeah, absolutely. A lot of, I know it sounds a very strange thing to say, but I think everyone's touched on it. There has been a number of, of positives that have come out. It's just the trick now is going to be stopping them from sliding back and trying to keep hold of those good bits as everyone makes the mad dash to get back to how life was before.
Yes, thank you very much. Because in the old days, Meals on Wheels was available, and I'm hoping some of these services are going to continue. Thank you.
Thank you, Councillor White. Councillor Renshaw.
Thank you very much, Chairman. Just going on from what Councillor White said, and it's very interesting, that is. I mean, I think that the general public is in a stalemate position. We all know about the risks of infection, but there's no evidence being published that if you get within 2 meters of another person, that person has contacted COVID and has been admitted. And so as a result of that, we've got less medication. Now, that's I really welcome that, because you often have a feeling that
difficult patients, particularly elderly patients, a doubt by giving them medication they don't really want for the condition, but it does keep them quiet. And research on this could assist the bill for medication in the NHS. And I know that there's a document which I see in my Amazon basket, which I never managed to purchase, and it's about taking less medication, and there's some value to that, and maybe some value on national research rather than rely on somebody publishing a book about it. Thank you, Chairman.
Yeah, I think that's an excellent point, and I would like to just comment on that, because I think that's exactly it, and I think that's the benefit, that unavoidably when you go into inpatient care, not only are there the usual medications, but then there are the impacts of the environment. So people invariably struggle to sleep. Usually it invokes more anxiety because of individuals being around. Medications are introduced. The work environment is very pressured. People don't have enough time to spend. I think going back to the previous point, the medications link into the fact that the model focuses on the individual in their home and their community, and that building of enabling, so building of personalised resources, looking at lifestyle management, looking at actually getting to the bottom of what the underlying causes of the anxiety, depression, sort of presentations are, rather than an individual being seen for a very short time in a consultation, whereby invariably medication is the first point of call, and in our older generations, is usually or can frequently be a cause of many problems as people get into multiple medications. Plus, at the end of the day, medications, they have their place, but they're only a part of the therapeutic process. They can't change, somebody's entire life. They can maybe modify it slightly. So it is about, as I mentioned earlier, going to that, actually working with individuals. And it's amazing because I think we've got into a picture where people actually want a quick fix pill solution, when in fact sometimes the solution to problems are far more demanding of the individual themselves, in terms of socializing, exercising, engaging in a therapeutic relationship. All of this actually entails quite a lot of personal resources. But that's what I meant by we're moving away from that paternalistic, here's a pill, will make you better, more towards a patient-centered sort of enabling philosophy, whereby we will work with you and able to address your particular problems, but you will have to work with us to do that. And that's where the medications go down, that we see it's personal resources, resilience and skills that come into play, and that's where the benefits of a more intensive home-based treatment come in. So yeah, absolutely, reduction of medications is a massive thing and incredibly important. So I think it's an incredibly valid point.
Thank you for that. Appreciate it.
Thank you, Councillor Renshaw. I've got Councillor Mrs. Woodson now, please.
Thank you, Chairman. Thank you for the report. It's a really interesting subject. First of all, you divided mental health and dementia, and the paper's on older people. Could you tell me what age do you class as elderly or older? And also, can you tell me how many people you've been caring for, and how you've coped since the pandemic with your mental health teams out in the community, care in the community? How did you get the message across to them? And did you have to have any personal contact? Because I'm very aware that there are people that must be within this cohort that have serious mental health issues like schizophrenia, bipolar, or any others. Thank you.
Yeah, so I'll take the last part of the question first, because it reiterates something that Jane said earlier, and that is the home treatment team in particular, they deal with our most acute patients who don't need to be in hospital. So by the very nature of that the face-to-face contact by that team has continued throughout the entire pandemic, because they are our high-risk patients, as you rightly say. Obviously, all precautions have been taken, but given the risks at play posed by their mental health condition and the risk, therefore, of going into hospital and the risks that carried for infection, that face-to-face has been a priority. So the home treatment team has continued with that. In terms of the broader community mental health teams, like I say, it's been an odd time because, as I think the graph showed, that when the pandemic first hit, that what we saw was a massive reduction in referrals as the GP services sort of closed down, and also people actually turning down visits because of concerns about risks introduced to that. So we've had to very quickly look at the alternate ways of working that Jane touched on, which is no small feat. It sounds like a simple thing to say, suddenly switch to digital offer. I've been in the organisation nearly 30 years, and sometimes we talk about digital offers for years and years without it happening. So to get it working within weeks is a fantastic thing, really. But that isn't without challenge in with regards to the patient group we're talking of. But what we have found is the use of telephone rather than video has been a high preference. We did, as an organisation, also undertake a very specific and detailed piece of work to ensure that not only the older adult services, but also my adult community colleagues, that we had contacted every single person on our caseload since the commencement of the pandemic, which again was upwards of 8,000 individuals. So again, was no small feat. But that piece of work has been monitored and the assurance given that every single individual has had a contact, even if they haven't been seen. So the teams have responded fantastically, not forgetting that a number of the teams themselves are affected as well by the nature of the vulnerabilities and risk factors. So obviously we've had to be managing both our own staff's vulnerabilities and risks at the same time as trying to keep all of those that we care for in contact with us and safe, and just allowing them to know that we are here if and as they. I've saved the most prickly question to last, which is, what do I consider an older adult to be? I'm going to play safe and just say that obviously, in terms of the cut-off point, so for mental health, so there's two separate things here. So our service for dementia, there is no age, so we deal. That's an ageless issue. So if it's dementia, then it's all age. For older adults' mental health, the traditional cut-off line is 65, but in reality, what we see is that the age-related specialism seems to kick in more around the 70 plus, especially if it's new onset of conditions. And there really is a difference between if somebody has had a lifelong condition and then just turned 65, for example, as opposed to somebody who hasn't, for example, had depression and then suddenly develops it later in life at 65, or suddenly develops a psychosis later in life. So again, they start to become quite different clinically, and therefore the specialism required for them kicks in. I think the other thing is that we're also now trying to be far more flexible about that. I don't like the term working age adult, because what does that mean anymore? It doesn't really define anything. And so we do also tend to look at other indices, so things such as frailty and multimorbidities, so people with multiple conditions and physical complexities. And sometimes you get somebody who's much younger than 65, but incredibly frail and needs our specialism. And we get people into the 70s, 80s who are incredibly robust and actually don't need a specialism and continue on with their previous care provider. So it's becoming an ever increasingly blurred line that we try to politically tiptoe around to try and offend as few people as possible. But the official answer is 65.
Thank you very much indeed. Thank you, Chairman.
Thank you, Councillor Mrs. Wootton. I've got Councillor Kendrick left now to speak, and then I've got a couple.
It's now been closed. I mean, if that's the case, then, well, I mean, it wasn't the best place to have a unit, as we all know, up on the first floor there at Pilgrim. And I guess that would really just leave Ward 12 for people who are below that magic age where they become older adults. So I was just wondering about that, because that would mean then, whilst obviously you don't need as many beds because of the success of this scheme, there would be no inpatient beds for older adults with functional mental illness on the coast there. I was just wondering about that, because people have. relatives will have to travel over to Brant, if I've got it right, which of course is a good unit now, but it's still a bit of travel there. I was just wondering whether there's any thought to that at all. Thanks, Chairman.
Would you like me to respond?
Well, if I come in first, Jane, and then Rafe. So just to pick up a couple of your points, Rob, about the provision of functional mental health inpatient beds. The reality of the situation is that irrespective of where a mental health ward is, we only need one ward. So wherever it is, it's going to be a single site model. And to state the obvious, wherever it is, it's not going to be everywhere else, because the numbers just aren't there. So we only need a single ward. And that's what the model has really hit that. And whilst individuals may travel more, I think the important thing is to focus on is that, as I mentioned earlier, we've had 394 referrals to this service that previously, prior to its existence, would have escalated potentially towards admission. Of those, about 370 weren't admitted. So that means 370 individuals and their families haven't had to travel at all. So the total number of travelling to access inpatient care is now significantly smaller than it's ever been. And all I can say, Rob, is that in the 22 months, I was going to say years, 22 months that it's been running, we haven't had any visitation travel complaints at all. We've made sure, so to touch on, I think, a different but aligned issue earlier, where there has been difficulty in access, we have supported travel for those individuals. We've also implemented things such as iPads as well, which have been amazingly successful actually during the COVID, for people to keep in contact with their loved ones and to give them greater options in terms of keeping in contact. But also importantly, since the implementation of the home treatment teams, I said that the length of stay for those who do go into hospital is also shortened by 39%. So for those who are going in, that the visitation, irrespective of the extra distance, is actually much shorter because they're going through the system quicker. So I know that still does mean that for a small proportion of individuals that there could be extra travel. But thus far, given the overall benefits of the model to the majority and also to the experiences of those coming through, and based on carer feedback thus far, that it seems that it's a balance that people are willing to accept. But obviously it's something we keep under constant review.
Thank you. It seems like a win-win situation, really. And again, I know we keep talking about COVID changing practices, but the point about the iPads and everything, it just shows what innovations can be made. I think that's fantastic. Thanks very much. Thank you, Chairman.
Thank you, Councillor Kendrick. Okay, I've just got a couple of questions myself now. On page 40, paragraph 6, the positive patient feedback is set out. Can you elaborate on the feedback from patients and their families? And would it be possible to share this feedback with the committee?
Yes, by necessity, and so as not to bore you all, obviously the paper that came is a truncated version of the full review that was done. And as I said, we've actually done 3 reviews during the 22-month period. So the feedback has been in numerous formats. So it has been via the standard friends and family process that we have, for all patients using the service, and the satisfaction ratings have been between 97 and 100% for satisfaction for the patients who've used the service. We also have the which I mentioned on the well-being ratings. Now that is a patient rated, so that is basically the patient saying whether they feel better or worse as a consequence of having received the service. And the results from that has probably been the most powerful set of information that we've had in terms of showing the positive impact on their perception of well-being, which is it's really important from just saying are they depressed or not. It's whether somebody feels better as a consequence of the service. And certainly the individualised wellbeing data, which we measure prior to service, then when we disengage, has all been in high levels of statistical significance in terms of outcomes. We've also obviously collect personal responses back, and as part of the engagement in the early days of service, we've actually done 2 rounds of stakeholder engagement around the service following the transfer from the ward to the community, which has been with service users, relatives, other organisations, GPs. So we've done a number of engagement events as well in order of reviewing and supporting the model. So it's been feedback from sort of as many sources as we can gather. Obviously, there are lessons to learn, that we find that, and that's where the feedback at each different iteration of the service that we keep on learning from, and that we keep on then keeping a view on the comments. It's great to hear the positive things, but we need to listen to the concerns. Some of the issues raised, for example, were around continuity of care, i.e. different workers going in on different days, and that, causing some confusion, in service users in terms of who was looking after them. So we were looking at that by looking at how we disperse the staff better. Some of the issues about changes in decision making across the pathway, especially if they went into inpatient care, which were addressed by aligning it to a single point of sort of decision making. So certainly, and also in terms of options around ways in which they're contacted and visited, because not everyone actually wants to be visited as often as we think that they should or that we could. So again, offering them different modes of contact. But yes, we'd be more than happy to share all of the feedback we've got. It's only for trying to keep the paper shorter that obviously we didn't include everything that's in there, but more than happy to share that with you.
Thank you, that's helpful. And finally, I think some of this has been alluded to in your comments to Councillor Kendrick. It looks like you'll be looking at moving to a single ward, and obviously Rochford is closed currently. So when is the targeted engagement or consultation due to take place?
If I may, Chairman, we raised that in the paper as something we want to do, but wanted to seek views from this committee to give the green light on that, essentially. I think 22 months in, it's high time we made a decision to give the staff certainty about but you're right, there are some wider implications in terms of Rochford ward being temporarily closed to fund this service. So we do need that targeted engagement. We're happy to commence it as soon as possible if you're in agreement with that.
I think we'd be in agreement with that. I think it's, like you say, it's high time, and quite clearly this is working, and it's working well. So absolutely. That'd be very useful. Thank you. In which case, I'd like to move to the proposal, and I'd like to propose that we note the progress with the older adults home treatment team service, and to list an item for a later meeting on the targeted engagement and consultation. Do I have a seconder for that, please?
Happy to second that, Chairman, if I may. Thank you.
Thank you, Councillor Bruce.
Thank them for the comprehensive way they've dealt with our questions.
Absolutely. Yeah, thank you. Okay, in which case, Trina, could you take the vote, please?
Yes, Chairman, sorry. It wouldn't work. Right. Councillor Carl-Macy.
4.
Thank you. Councillor Chris Brewis.
4.
Councillor Bill Bilton.
4.
Councillor Susanna Barker-Milan.
4.
Thank you. Councillor Matthew Fido.
4.
So Mrs. Sandra Harrison.
4.
Rob Kendrick.
4.
I don't know, that's unanimous from the members present, Chairman.
Thank you, that's carried on. I'd just like to thank our presenters, both Jane Marshall and, of course, to Steve as well. Thank you, and to everyone else that's probably ducked out by now, but thank you all very much this morning.
Thank you for taking the time to listen to what we had to say to you in the committee, Chairman. Bye-bye. Thank you.
Thank you. In which case, we'll move into agenda item 10, the integrated urgent care. I would like to welcome to the meeting our presenters, Maz Fosh, the Chief Executive for Lincolnshire Community Health Services, and Tracy Pilcher, Director of Nursing for Lincolnshire Community Health Services Trust. I'd like to hand over you for the presentation, and we'll take questions at the end, please. Thank you.
Thank you very much. Thank you very much, Chairman. Just to say, I will only be able to be available until a couple of minutes before 1 p.m. But Tracy will be here throughout and being able to take any questions if we overrun on that. So I'm just going to start by just doing a brief introduction, and then I'm going to hand over to to Tracy, who's going to take us through the full paper. So for a bit of background context, Lincolnshire Community Health Services, we see approximately 123,000 attendances in our urgent treatment centres and minor injury units per year, and we manage approximately, it can increase 10,000 calls on our clinical assessment service per month, and this can increase either during winter months or, of course, and we will cover during COVID-19. Our paper is focused on our integrated urgent care offer, as it is important to recognise that not all attendees require physical attendance, and this is a key part in how we are contributing directly to tackling national challenges, such as reducing the A&E attendances and admissions through using our clinical assessment service, for which does form part of this offer. We have also introduced e-consultation and e-prescribing, which again can improve patient access, quality, but also patient choice. And we offer bookable appointments and home visiting services where appropriate. And some of you may have also seen more recently our Talk Before You Walk public campaign to direct the public to call 111 first in order to be directed to the best possible place for care and advice. This could be from self-care, directing to a community pharmacy, bookable appointments, or coming and having physical treatment. I think it's really important to also stress that we are still responded to COVID-19, and our Talk Before You Walk campaign is absolutely about the safety of our patients. I'm going to pause at that point and hand over to Tracy, who's going to provide more information, more detailed information of our services and, of course, how we have responded during COVID-19. So thank you.
Okay, thanks, Maz, and good morning, everybody. As I say, I'm Tracy Pilcher. I'm the Director of Nursing, AHPs and Operations for Lincolnshire Community Health Services. So originally, the paper you've got in front of you, we had written this to come to you in March, and then obviously with COVID, there's been the kind of rescheduling. So there's a combination of information in the paper around the initial focus, which is around our Lincolnshire integrated urgent care services. So I'm sure people are familiar with the different services that we offer across Lincolnshire, but up until about a year ago, these were all very individual services. So we have 111, our clinical assessment service, and we had urgent care services. So in October and December of last year, 2019, we transitioned those urgent care services into urgent treatment centres. And the main difference with urgent treatment centres is they've got 27 standardised standards that form that integrated urgent care offer, and they need to be integrated into the wider pathways of care, and that's been a significant part of the work that we've been doing. So the urgent treatment centres originally were Louth, Skegness, Boston and Lincoln. Boston and Lincoln prior to this were what we describe as GP streaming services, but they now operate in that 24/7 walk-in service, but also able to do bookable appointments, that integration into clinical assessments. But then moving on, we have spent a lot of time also standardising and strengthening our homes treatment service. So as well as being able to treat patients in what we describe as our building-based services, we also have a home visiting service which goes out to see patients on a 24/7 basis, so that if we do a clinical assessment with a patient and identify that we need to see them face-to-face, we can make a decision at that point where that face-to-face visit is bringing that patient into one of our urgent treatment centres, or whether we go out to see that patient. And I think that's a real benefit to the patients, and it does really help us to understand where we need to focus. Part of our clinical assessment service also integrates with EMAS, so that if there are crews on scene. So if EMAS have a crew on scene and they need to think about a different pathway rather than bringing the patient into an ED service, then they can ring through to clinical assessment service, and we can offer a number of different pathways across Lincolnshire, as well as treatment in either a UTC, through our home visiting service, or one of those alternative pathways. And again, I think that's a real strength of the service that we're providing across Lincolnshire. There are 5 key areas of the National Urgent Care Review, which identified, as well as having lots of different types of services that the public were saying they were finding really confusing. It was also about trying to make sure that we provided services at home and provided that better support for self-care, and that would integrate into community services and community pharmacy and other elements of self-care. We wanted to make sure that we're helping people to receive that urgent care service in the right time and in the right place. And again, a lot of that is looking at making sure that either patients aren't coming into urgent care services or hospitals unless they really need to, but also we have a lot of different services that we can offer to patients that they may not necessarily understand. So underneath our 111 and clinical assessment service are a number of different pathways of care, but also a DOS, which is the directory of services, which will enable us to signpost patients into those services. What we wanted to focus on is how this the LCHS integrated urgent care offer supports that key element. So providing better support for people to self-care and patients with long-term conditions. I think this is really important. A number of patients will phone through to 111, or our clinical assessment service will phone them back, and actually it is either some support around the medication they're taking, some support and advice around their long-term condition, and then we have specialist services such as our diabetes, services that we can signpost patients into or provide that immediate support to. And again, I think that's something where really understanding how we maximise those services for patients. We then have the ongoing focus around making sure we are providing advice and support and video consultations for patients at home. So if patients phone 111 or go online, and it's not an emergency, then our clinical assessment service is ringing back about 70% of patients. And in that assessment, what they're trying to do is, again, either offer health advice that we can prescribe electronically and have that delivered to their local pharmacies, or we can book patients into either a primary care appointment, an urgent treatment appointment, or advice to go to A&E. So those are a number of different outcomes for patients. Sure, people have started to see, we've done a lot of work in LCHS around our Talk Before You Walk campaign. And again, what we're trying to do is make sure patients are only coming into services or into building-based services if they absolutely need to. And if there is a different way of us being able to treat that patient, we are doing that through that Talk Before You Walk campaign. The other area that we focus quite a lot on is trying to maximise the use of our video consultations. So we have got a platform that we call Q Doctor, where we can offer patients video consultations. So for instance, if a patient has a condition and we do want to see it, so it may be a rash, then it is better if you can actually see clinical assessment services onward referral into either a community nursing or one of our other services. So again, it's really trying to make sure that we're maximising both the services as well as our options for patients in terms of all of those services we have on offer. We've talked in the paper around our urgent treatment centres and the impact on that. So I've said Lincoln and Boston are both co-located with an ED. Louth and Skegness are our walk-in and standalone services, but they are both offering, and we've gone through some of the changes we've made as part of our COVID response. We've then gone on to look at some of the, I think Maz has talked about some of the numbers, so the numbers of patients that we're actually seeing. So certainly we do see a different activity profile over weekends. So obviously for patients in terms of out of hours services. And also what we have seen as part of our UTC is really that part where people have given us a lot of positive feedback about the UTCs, being seen very quickly, being seen and treated and discharged. And at the moment, for our UTs, our general kind of performances, we're seeing discharging patients at 97%. So again, that's quite significant in terms of the way that we're managing patients and the support. Do you want me to pause or just go on to the COVID response?
If you could just go on to the COVID response, we'll take all the questions at the end that way, I think. Thank you.
Okay, so as part of our COVID response, we've seen our clinical assessment service increase in activity quite significantly, and that first started around February, March. Obviously, the changes with 111 and how we were trying to direct patients and provide that support. So over the course of the COVID response, we've seen activity in our clinical assessment service increase by about 21%. We have increased staffing, and that's been one again of our COVID responses, making sure that we have additional staff available to be able to respond to those patients. One of the things we did note, and it was quite a significant decrease in patients generally accessing our urgent care services, and I think we saw that across all of our Linkershire services, but particularly our minor injury units. So the two minor injury units that we still had operating was Spalding and Gainsborough, and we saw quite a significant reduction in patients accessing those services. The other thing that we identified was as X-ray facilities on those two sites was removed to enable the redeployment of staff, actually again the types of patients we were able to see in those services was reduced quite significantly. So we took the decision jointly to temporarily close those services as walk-in services, but focus also on our home visiting, some of that clinical assessment and video consultation approach to those patients, and that's been something we've continued to do as part of our COVID response. So at the moment, Gainsborough and Spalding both remain closed for walk-in, although we are seeing quite a number of patients, particularly at Gainsborough, through our home visiting, and then we are bringing patients in for booked appointments if that's appropriate. We've taken the opportunity to do some refurbishment at Gainsborough to ensure that some of the waiting area is more COVID kind of secure, and also making sure that we could understand and make sure that patient pathway is more appropriate. That work's just been completed, and we are now just working through our kind of start date to restore that service at Gainsborough. The other thing that we identified as part of COVID response, as I say, is the general reduction in some of our urgent care activity, and also the need to increase our staffing within our clinical assessment service. So we took, again, a joint decision to close, to walk in at Louth and Skegness, but still have the ability to phone through to the clinical assessment service and video consultations. And those two services at the moment are still seeing quite a significant reduction in what we would normally see at this time of year. So they remain closed to walk in between 10 o'clock at night till 8 o'clock in the morning. But then we have still got, as I say, our home visiting, booked appointment and other options that we can provide for patients. And then as part of our COVID response, we were also asked to provide a UTC, so an urgent treatment centre at Grantham, and that started on the 22nd of June of this year. So the urgent treatment centre at Grantham is operating as a 24-hour a day, 7-day a week walk-in service, but again has all the other features of our UTCs. We do provide the clinical assessment service, the booked appointments and the home visiting service in this area, and that enables us to see patients through those services, but also look at making sure that we're managing as many patients in that local population as possible, working very closely with primary care and the other services that are operating within that area. Thank you very much.
That's lovely, thank you. In which case, we'll move into the questions. Councillor Wotton first, please.
Thank you very much indeed, Mr. Chairman, and thank you, Tracy, for your long report. I want to focus on the last thing you mentioned, which was Grantham UTC. Clearly quite an emotional and important topic for the residents of Grantham.
Yeah.
I'm a county councillor, I'm also a district councillor, and we get our last emergency council meeting on the 1st of July, unanimously voted that we want to see a return of Grantham Hospital A&E back to level 1, and the temporary UTC at Grantham should be that, temporary only. Now, I've had cause to speak regarding complaints from residents who have been barred from going into UTC by the security guard on the outside, or phoned up 111 and tried to be coerced in going to other location for an appointment when it should be a 24-hour walk-in centre. Even I, when I went to have a look at the unit, was asked, did I have an appointment? And I said, no, thank you, and just walked straight in. Can you explain why they're doing that at the moment, and the fact that it gives some reassurance to the people that they shouldn't have appointments, just walk straight in?
Yeah, absolutely. Thank you for that question. You're absolutely right. It's a 24/7 walk-in service. The site itself at Grantham is now what we describe as a green site. So we're trying to protect the services across Grantham to ensure that planned cancer and urgent services can operate from that site safely. My understanding from the kind of signposting is that the security, as it's described, is there to help and support signposting patients and to ensure that patients aren't coming onto the site unless into the green site unless they have an appointment. The actual UTC is in what we describe as a blue bubble, so there's a number of services that are in the UTC, and we have spoken at length and tried to reassure people that actually they may be asking where so that they can signpost patients, but actually all they're asking is a clarification question to support that signposting, and that patients can walk into the UTC 24 hours a day. It is a walk-in service, and also we have been trying to educate the people that are signposting to ensure and reiterate and clarify that message that it is 24/7, it is walk-in. They're asking questions about bookable appointments, and yes, we do have bookable appointments, but primarily patients are accessing that service as a walk-in service, so we are supporting that.
Chairman, if I come back, please.
You may.
Just one further question. When does your contract run out as a UTC in Grantham? And also, I wish to compliment you and your staff at the hospital, because those who have received treatment there have been very pleased and very thankful for the service they've received.
Okay. So would you like me to come in on this one, Tracy? So thank you for your question. Just to confirm that we're working in partnership with United Lincolnshire Hospitals NHS Trust. So we have a memorandum of understanding that at this present time is running until the 31st of March in order to support their restoration services under COVID-19. And thank you for the comments on the staff. Appreciated.
My pleasure. Thank you, Chairman.
Thank you. Just building on from Councillor Wootton's comments, I find it very odd that you haven't got a contract in place that is actually there. And I would have some concerns as to what will happen with your staff should this end and it returns to an A&E at the end of this period.
We have a formal memorandum of understanding that we are working
as well. What about when that period of time ends? What will happen to the staff that are now located at the UTC? How will they be redeployed and so on?
So the staff at the UTC are a combination. So the staff that were the ULHT ED staff are remaining in place. So the staff that were there as the EDs, because we thought it was really important. The local population are used to seeing those staff. They're used to that kind of support from that local service. So they are remaining in place. No staff have been moved from ULHT onto other sites. And then we've complemented that with our LCHS urgent care practitioners and out-of-hours service. So it's a combination. The matron working on site is Michael Brunton, which is our matron, because we think it's really important that we have that leadership role in place. And obviously we've been doing a lot of work with the staff on site about how the integration works, because that's a different model to the ED model. And also because SDEC, so the same day emergency care service, is being provided by ULHT, we're also making sure that pathway through to SDEC is in place, as well as working with the mental health liaison team. So the LPFT mental liaison team are also located in that front door. So we're trying to, as much as possible, make sure that the local population have access to the kind of majority of services that they had access to previously.
Okay, thank you. And again, just following on from what Councillor Wootton said, I'm sure several members of the committee have received complaints that when people are trying to access the service via 111, even for services that should be available at that UTC, they are being told to either go to Pilgrim or to Lincoln Hospital. Can you give an explanation as to why this is, and is this being thoroughly investigated?
Yeah, so when people phone 111, the 111 call handlers, so they're not clinicians, they're call handlers, work through what they call a directory of service. So, and that profiles different services in terms of what is on offer. So if somebody calls with a condition that would normally be seen in an urgent ED, so an emergency department, by default, Grantham won't be offered to that patient because that condition that they're describing would normally be seen in an ED. We've gone back on each of these occasions to try and work with 111, so we work very closely with 111 and the Directory of Services to try and make sure that profile does adequately describe the services that are on offer at Grantham, because what we've also heard is when those patients then go to either Pilgrim or Lincoln, they're actually seen through our UTC, so in our urgent treatment centre. So we have picked up each time that has happened. We've been doing some work, our medical director Yvonne Owen has been doing some work with the Directory of Service just to make sure that where that disposition happens, we can try and maximise the number of patients that are accessing that service at Grantham. But some of this is the profiling that sits underneath the DOS. So we are working each time that this is brought up, trying to make sure that as much as possible we are offering Grantham and making sure patients can be seen in that local environment.
Thank you, because I'm sure the rest of the committee will want that reassurance. Yes, certainly.
Can I just also come in and just say, just to further that, if you do get any complaints like that, we really want to get those cases brought to our complaints and PALS service attention so we can respond to them in a timely manner and use those as the live examples in going back to 111 and ensuring that we've got that thoroughly looked in, and if there is a problem we can get that rectified. So your support on that, and again anything that we get pick up through a social media perspective, we also are directing them to our complaints and PALS team. So thank you.
That's great. Thanks, Ash. That's very, very helpful, Maz. Okay, we'll move on to Dr. Woofy, please. This next question.
Thank you, Chairman. Dr. Brian Woofy, Health Watch Lincolnshire. First and foremost, I would say how much we welcome this paper. I don't think it's been widely circulated yet, but those of our organisation who have seen it have joined with me in welcoming. I've been trying to get some clarity in integration of emergency care for a long time and have spoken at Health Scrutiny on a number of occasions on this. So it really is a welcome document. And anything that I'm now going to say, which is merely questions about detail, want to be taken in that context. I think you've made a big advance. And I think the confusion, which you have mentioned here, for patients, which has been going on for a few years now. In fact, things were almost getting worse in the early 2010 plus time, I think are hopefully going to be reversed. So that's very good. As far as I have got some questions on going through your paper, page 2, paragraph 1, it talks about integrating or working with neighbourhood teams, but there's no mention of primary care networks, which unfortunately are not coterminous at the moment with neighbourhood teams, which isn't a very good signal of integration. So I hope that is probably taken for granted that you will be working right across the board. And the second thing on that is, can you say something a little about the staffing of CAS, who actually is there or who is available within CAS to make decisions, and whether the old GP out of hours service is still functioning, or is this all integrated into this? But it doesn't seem to have much of a job to do now. So probably the answer is no, but perhaps you can confirm that. Going on page 2, at the bottom, there's talk about patient confusion and clarity, but then it goes on page 3 to talk about what is really follow-up for chronically ill or long-term care, and 3.1 is not very clear as to exactly what it means. It's got quite a lot of jargonese in it, but I think the average person would have difficulty with that, and I wonder whether that could be clarified and rewritten. On page 3, paragraph 2, it talks about urgent care centres will be integrated and co-located with local urgent community services, and I don't really know what that means in practice, and perhaps you could just make some comments about that. And page 4, paragraph 3 talks about CAS for all care homes, which sounds absolutely great. Does that mean there is a direct link from care homes, or do they ring in and take their turn with everybody else? And just some clarity there. You then talk about on paragraph 4, page 5, that the average wait for callback from CAS is 56 minutes. And I do just have a bit of sort of quivering that this is the beginning of an A&E delay process that might get longer the more popular CAS and 111 become. So I don't think 56 minutes for somebody who's quite anxious is something to be too satisfied about, and no. I'm sure you're not as well. The other thing is, can 111 cope? I think we all know 111 in its early days had a lot of teething troubles, and even when it should have been not teething, it was still teething. And so the new 111 working with CAS, which always was a good idea, can you just reassure that that is now working and people can get through quickly without waiting too long? And on page 6, para 5, you talk about the Gainsborough and Spalding MIUs. It's clear from the paper what is going to happen to MIUs, because they're not really in the future development plans. But I'm sure if I don't say something, Councillor Brewis will, about the fact that a place like Spalding is quite isolated if it's only an MIU and not a UTC, or is it going to be such? Because I think it really is a very good step forward, this paper.
Okay. Matt, which way do you want to go in first, Tracy, and then pick up if you need me to come in? So if I start with which I think is the first question, is who is in CAS? So clinical assessment is a service that we offer, and there are a range of practitioners that are in the clinic. So there are what we describe as specialist services, so some people with some of the kind of low-level understanding of minor illness, minor injuries, or urgent care practitioners. So they are registered. These are professional registered people who have had additional education and training to be able to manage patients, both from an urgent care perspective, but also from a remote, because obviously this is remote consultation, so those are the two things. We also have GPs that are part of our clinical assessment service. So again, what they tend to do is the calls will come through, and depending on what call type it is, it'll be clarified around whether this is somebody that needs a very specialist kind of clinical consultation, or whether there is, whether it's a health advice kind of conversation. So they are stacked on what we describe as a stack, and then they're pulled off, and the appropriate practitioner, if an individual practitioner isn't able and doesn't feel they have the right skills or competencies, they can escalate the call. So there's always somebody that they can escalate the call to, to provide additional support. And then we have a matron level person, Darren Freeman, who oversees our clinical assessment service. And we staff the clinical assessment service against the profile of activity. So we do tend to find with our clinical assessment service, it's quieter in the morning and it increases. So again, our staffing profile is across that profile. And also you can log on anywhere onto clinical assessment. So if I'm a practitioner sitting in this office and it starts to get busy, I could receive a call to say, can you log on to clinical assessment and start? So that's where it's a really agile approach. And obviously as part of COVID, those staff working aren't sitting in one place, they're sitting in a number of places that they can kind of integrate into clinical assessment. So hopefully that kind of clarifies. We are always reviewing our clinical assessment service and making sure that we do match activity and demand. And one of the things that we noted at the beginning of COVID, we hadn't anticipated that initial increase, and it started to increase over a number of weekends. So we quickly reprofiled and increased our staffing levels to give that. I think that does talk about the average wait time. So at the moment, and on some days of the week, the callback is within 10 minutes. So it's not, that's the average. And that includes, as we talked about, quite long delays over the winter where we hadn't quite got our activity profiles right and we've got an increase in activity. So that's why we've always looked at increasing our clinical assessment service. And one of the things we've done this year is increase our staffing levels across our clinical assessment service to ensure that we can ring patients back within a much quicker time period, because you're absolutely right, that's not acceptable and it's not the standard we want to deliver for those patients. I put clarified page. Your second question, Dr. Wookey, was around, I'm sorry, I wrote it down. Do you remember your second question?
Second, maybe third. It was yes, it was about whether the GP out of hours is still in existence, and then we went on to the integrated and co-location.
Yeah. So we still have out of hours service in certain locations. So where we haven't got a UTC, so where we've got UTCs, we've integrated out of hours into our urgent care service to develop that UTC. Where we haven't got a UTC, we then have our clinical assessment and our home visiting service, and therefore some of the areas such as Stamford, where we had a discrete out of hours service, we're still providing that service. So depending on the location across Lincolnshire, where we haven't got a UTC, we then provide an out of hours service. So they are still there. We still have kind of a workforce that are working under out of hours, and they work in specific locations according to what we're being asked to deliver in that location. So MIUs, I think, was the other question around whether we don't know at this moment in time around Spalding and Gainsborough. It's for commissioners to decide what they want in those locations. So we're very flexible. We absolutely see those MIUs, as you described, being there available to provide healthcare to vulnerable populations in isolated areas. We were working with commissioners prior to COVID to look at trying to either move those into UTCs or for the commissioners to describe what they wanted in that location. Obviously in Spalding, the MIU as it was is co-located with our GP service. So again, there's an opportunity around an integrated urgent care kind of primary care hub. And the MIU at Gainsborough, there does, particularly for that population where they have poor road infrastructure, they are a vulnerable population. Again, it's understanding how we provide those services. So at Gainsborough, on site at Gainsborough, we have our community nursing service, we have other services, and that's when you talk about where the co-location is and that co-location to other services. Obviously, as I described at Grantham, the co-location is we have what we describe as an assisted in-reach service. So it's our service where we can look at patients going into community-based pathways of care. So a community-based pathway of care would be where we are wrapping around an individual patient, community nursing, some of our specialist services to make sure that we're able to look after them at home. We've obviously got the mental health liaison service co-located at the front door at Grantham, and we've got the same day emergency care. So depending on where the service is, depends on what other services are as we described, co-located with that service. The CAS for care homes is exactly as you described. So the clinical assessment service, there's a special number. So all the care homes across Lincolnshire have access to come straight into our CAS service. So they phone through to our ops centre. They're given an option to then phone straight through into our clinical assessment service. And again, this is about providing additional education support and advice to care homes so we can maximise patients being treated at home, whether they're at home in their physical home or if they're in a care home. We see that the same thing. It's about making sure that we're providing additional support and care for those patients. And then from a 111 perspective, so 111 is still being delivered by DHU, which Derby Health Services. So it's not actually us that provide the 111 service, but we work very closely with DHU and the commissioners to make sure that that's integrated into our clinical assessment service. So normally if a patient phones 111 and they need additional support and advice, what they'll do is transfer that call into our clinical assessment service, and that's when we call the patients back. So when you see the callback times, that's what we're describing. The callback from 111, the call handler say, we're now going to pass your call on to a clinical assessment service, and then us being able to contact that patient and then start to provide that care and advice and support for that patient.
Thank you. Just one follow-up, and that is, those are useful answers to the question. Do you think perhaps, without wanting to make the paper any longer, some of those details might actually help people who are not familiar with all that is going on in the health service and want to know what to do? So a description of what people should do and what the functions of the various bodies are would, I think, be really useful if this goes out on a wider audience.
Okay.
Okay, thank you. Thank you, Councillor Dr. Wookie.
Thank you.
I'm acutely aware of the time, and it's very quickly evading us. So I know that, Maz, you have to leave in about 5 minutes. So if we can try and keep it as robust as possible. Okay, Councillor Whittington, you're up next, please.
Thank you very much indeed, Mr. Chairman. Thanks, Tracy and Maz, for the report. Like both councillors around Linderwood, and I'm also a Grantham, both county and district councillor. I have had a few of my residents contacting me about the 111 service and have been directed elsewhere. Looking at it, the activity level seems to be all over the place, and I suspect that a lot of that is to do with COVID. I know there's been quite a bit of sort of anecdotal evidence that during COVID, people have been less reluctant to go into the health service, because they're not sure if they've potentially don't want to infect people. They've heard stories on the news about the health service being inundated. So I think people may have been holding back. I'm just wondering, on a previous paper we've had around this, the Mental Health Trust have done some modelling work around trying to establish what they think activity levels could potentially look like post-COVID, or when we're getting towards term this new normal. So just a bit of clarity around what you've been trying to do around that. And the second sort of question is really around, and I'm thinking in terms of people who deal with situations on the ground. An example, I'll give you 2 examples. For instance, my mother before she went into a care home, had several falls at home, and she sort of went by ambulance up to Grantham Hospital, and invariably ended up in one of the medical beds at Grantham before then sort of working through the system and then going back home. And I'm just wondering how that's going to work now, because the number of medical beds at Grantham Hospital is being quite considerably reduced. So what happens in those sort of situations? And also, I played and coached rugby for many years, and quite often during either a game or doing training, it's a physical contact sport, as are other ones, and something happens. A player goes down, Now, if it's really serious and it's obvious that it's serious, I mean, I once refereed a game. I heard the player's leg break as he went down. So I mean, that's straight. We call an ambulance and whatever. But there are some situations where you're not quite sure how serious the injury is. You've got a walking wounded, and invariably they've been put into a car and taken to the hospital, as it were. And I'm just wondering if you get somebody there. Because people, they'll deal with the situation, they'll go to the hospital. Now, it might be that if it's a minor injury, it doesn't really matter where they go to, they'll be patched and sent home. But I'm just thinking where they go to, where there's either an MIU or a UTC, if it's more serious, and I'm also thinking in terms of one of my relatives who sadly died from meningitis, but her symptoms presented themselves as influenza, and again, it's if people turn up, just walk in to the. I wouldn't say the wrong unit, but if they go to an MIU or a UTC and actually they need an emergency department, what happens then, as it were? Because people do. They've got walking wounded, they just go to hospital and they're not entirely sure. Which then comes back to my third point around, I know you've done some work on communications around letting people know what different hospitals provide. I'm just wondering what you've done so far around that, and do you think there's any more scope to potentially improve the communications to sort of go out and really start to re-emphasise a lot of these messages about, what to do? Because, I remember when my son was growing up, he went to Grantham Hospital A&E 3 times in about 2 weeks. He fell out of a tree. He fell off his bike. He was playing around with some railway sleepers in somebody's garden that they were using as a border, trapped his fingers. And when you're a parent, like, you just bundle the child in the car and you just go. And so it's that sort of just a reassurance about what happens in those particular sort of situations would be really useful. Thank you, Mr. Chairman.
Okay, so I think if I pick this up, because I know Maz needs to go. So I think from a point of view of somebody with a minor illness or minor injury, obviously we have X-ray facilities on site, so we will still be able to see patients, X-ray, and manage kind of some of those conditions directly on site, and some of that is just the assessment component. If a patient comes into the UTC, deteriorates and requires inpatient care, then obviously we would transfer that patient to a site that has inpatient facilities, because I think that's part of the green site. There are no medical beds on site at the moment, and therefore there's no admission pathway from the UTC onto an inpatient facility at Grantham. So if the patient's seen at home by EMAS and they are unwell and they know that they need an ED, then they will transfer straight to a site with those more complex services available. If they do walk in or brought to Grantham and actually they do need more complex care than we can provide at Grantham, then obviously we would transfer that patient to a site that can provide that care. So I think there is something about once the patient is received within a service, then it's for us to assess whether we can deliver that level of service, and if we can't, then we would transfer that patient to a site that we can. I think the question about falls at home, I think, is a really important one. So if a patient is constantly falling at home or is at risk, then when I was talking earlier about our assertive in-reach team, that's part of that care package that we give. Transitional care is about making sure that from an occupational therapy perspective, we've assessed that home, we've looked at the risks, and we've provided advice, some aids sometimes patients need at home to enable them and support them if they are falling frequently. And that would all be part of what we described earlier as our integrated service offer for patients. We have got access to transitional care beds as well, and we can admit straight into transitional care beds. So I think there is something around those broader options that we can provide for patients. We do, and we absolutely understand how confusing and how difficult it is for a patient to think about what services are on a site, which is why we are so focused on trying to do the Talk Before We Walk campaign, so that actually we aren't bouncing patients from site to site, because it's not obviously convenient for the patient, and it's not appropriate for them. The public won't understand every service that's on offer on every site, which is why we're trying to signpost patients through our Talk Before We Walk campaign, so that we can direct them to the most appropriate service and site that will meet the needs that they have and according to what condition they have. And in terms of, I think the other question was around activity profiling. Absolutely. So in terms of our 2 UTCs at Lincoln and Pilgrim, they are up to pre-COVID activity levels, so pretty much back to where they were previously. Skegness and Louth aren't part of that, is we haven't seen the seasonal variation. So we often see quite significant seasonal variation at Skegness, and we haven't experienced that yet, but we are prepared for that increase. So all of our restoration plans, and I think we spoke last time when we came to Health Scrutiny Committee about our recovery plans and how we're making sure that we're stepping services back up, include one, if patients, that we've got a backlog of patients, but also making sure that we're able to model activity and our services to meet any increase in demand. So hopefully
does that answer your questions?
Absolutely. Thank you very much, Tracy, for your answers. Thank you.
Thank you. I think I'll come in with my question at this point, because I think it feeds in quite nicely to what you've just had to say. I understand you haven't seen the seasonal variations as of yet, but officially speaking, the schools have only just broken up. Now, you know, it's a major concern for myself on the coast that we haven't got that access overnight. You know, I think you'll find an influx will begin from this weekend, and there will be that need for it to be reopened. Not only there, but Louth, of course, as well. Very popular for the Wolds Walks and so on. So can you give us some assurance as to when they will reopen overnight, please?
Yeah, today I can't say the date. We are monitoring very carefully the activity, and as I said, we have got home visiting, so it's not that there are no access to services overnight. We do have our home visiting service. We do have our booked consultations on our clinical assessment service. So we are monitoring this really carefully, Councillor Macy. And
first of all, I've been contacted by residents who have said when they've attended the UTC, they've been treated with great respect, there was lovely staff, and they've had excellent care. And that goes against the negative of some of them didn't like to be questioned at the door, but you've explained that fact. But Dr. Wookie already brought up about GP out of hours service. Now, that is still on the sign at Grantham Hospital. Is that still working, the GP out of hours service, along with the UTC?
Yes.
And if so, will there be a division of the figures of those that have seen within the GP out of hours service and your own figures?
They are one of the same now, so that in terms of the UTC includes the out of hours service. So it is, we can divide in terms of the hours, who's had a booked appointment overnight and who's were walking overnight, but actually they'll be seen in the same service. So that's part of the integrated urgent care, is the combination of those two services have come together underneath integrated urgent care.
Okay, thank you for that, Tracy. And then I was fortunate enough to get a question to the board meeting that you had sort of earlier on, and you kindly answered my question. And my question was, how many people have you had to refer to go to an A&E department elsewhere? And at that time, it was 3.88% of the people, which amounted to 44 people. Now, I'm assuming that's figures gone up by now, and I just thought the committee would be quite interested in that, and in particular our chairman, because to me I think that proves the point that we do really need an A&E service in Grantham.
Okay, so yeah, we monitor this as part of our daily report, so we're monitoring this very carefully. So over the weeks, the figure is in between 3 to 5%, so it hasn't increased at all. It is in on a weekly basis, as I say, the 5% was the first week, and then the last week was 4.22%. So there is something about that seems to be the 3 to 5% is the numbers of patients that are then referred on from that service into the ED service.
Right, thank you, Tracy. And then the sheer fact that now people can walk in to the UTC rather than having to wait for a GP appointment. I assume that some of our GPs are not going to be too happy about that in the future.
I mean, primarily it is part of the UTC. You know, the urgent treatment centres are booked appointments to see a GP, and it's a GP-led service, so there's a combination of practitioners. I haven't heard, I think we've worked very closely with the local Dave Baker, you know, Dr. Baker in the local kind of area. He's very supportive. We've been working really closely with him about making sure that we maximises. I mean, he is very passionate about the services at Grantham, as you know, and has been really focused on making sure we're maximising those services and the offer to the population across Grantham. I haven't heard that they're not happy that we now have booked appointments and you can walk in. I think they see it as part of that broader working together and supporting the local population.
Okay, thank you, Tracy. And also there was some confusion whether the x-rays are still being done at Grantham and bloods, and if you can explain that or how you get the message out there to people.
Yeah, so if you are seen in the UTC and you need bloods or you need an x-ray, they are undertaken. So the x-ray facility is operating the same now as it was previously. There isn't an x-ray facility overnight, but there is an activity requiring. So if a person arrives or is phoned overnight and they need an x-ray, we can book them in the next morning to have an x-ray. So there is that kind of option of booking patients in for x-rays the following day, and that would be through the UTC option. Again, if you access the UTC, you are then accessing bloods are taken in the UTC, and clearly if there are any other diagnostics, we can organise those through the UTC. I think previously the GPs on site would refer for bloods on site, and I think that's the service that has changed as part of the green site option.
Okay, thank you, Tracy. Thank you, Chairman.
Thank you, Councillor Watson. Okay, finally, we have Councillor Brewis, and then I'm going to close down the debate. Councillor Brewis, you're up.
Thank you very much. I think it's been very comprehensive, and Brian Wookey has said some of what I was going to say. I think perhaps the reduction in minor injuries, what we call minor injuries, is partly people deciding all of a sudden minor things they'll deal with themselves at home like they're used to. Example, the ultimate one, get stung by a nettle, you go and get a dock thief. So I think there are quite a lot of that going on. The demographic of the county and those who are not contactable by technology is a bit of an issue, and I wonder whether you're addressing that, particularly in the eastern half of Lincolnshire. And as for UTC at Spalding, the one advantage of UTC at Spalding, if I was in Spalding at the moment and I needed a UTC, the difficulty of negotiating Boston, I'd probably go to Peterborough or Kings Lynn. And if there was one there, it would reduce the number of people who have to go out of county. Now, where I live, obviously, 8 miles from Wisbech and 9 miles from Lynn, there's no way we're probably going to go anywhere else in the near future. But I think we need to look at the fact that we are trying to encourage more people to use our own services within county. So I'd welcome your observations on that. Thank you very much.
Yeah, so I think from a perspective of us as an organisation, we are, you know, we will provide what is asked of us to provide. So if the CCG decides that it would like a UTC at Spalding, then obviously we'll provide a UTC at Spalding. It is a commissioning decision about what type of service they think is the appropriate service to meet the needs of the population.
Okay, thank you, Tracy, for that. I think that's helpful. Okay, I've just got one question left, and that is, with space being at a premium currently at Bilbram A&E, how are you going to facilitate the rebuild of a UTC alongside this?
Yeah, so at the moment we are in a different location at Pilgrim to support some of the working. So we've moved our UTC to about three different locations over the course of the last few months to support some of the segregation of the pathway and making sure that we've got the ability to socially distance and do the other things that we need to do. There is a whole build plan, so there's a project group and a build plan around how they're going to re-provide the Pilgrim, and it's a UTC, but also increasing clinical space for the urgent the A&E department as well. So that will be all part of the build plan to make sure that we can continue to deliver services on the site and meet the needs of the population.
Okay, thank you, that's helpful. In which case I'm going to move to the proposal. I'd like to thank our presenters and request that we note the report and have a further update in 3 months, specifically around what we're hearing in Grantham in terms of those that are being diverted incorrectly and so on. Do I have a seconder for that proposal?
I'll happily second that, Chairman, if I may. Thank you.
Thank you, Councillor Brewis. In which case we'll move to the vote. And Trina, if you could take the vote, please.
Thank you, Chairman. Right, starting then. Councillor Carl Macy.
For.
Councillor Chris Brewis.
For.
Councillor Bill Bilton.
For.
Councillor Susanna Barker-Milan.
I believe she's left.
Councillor Matthew Fido. Councillor Harrison. Rob Kendrick. Colin Matthews. Thank you. I can see he said 4. Councillor Robin Renshaw.
For.
Councillor Glynis Scalese. She's not here. Councillor Angela White. 4. Councillor Mark Whittington.
4.
Councillor Stephen Woodliffe.
4.
Councillor Linda Wotton.
4.
Resolution from June in relation to in relation to developments in Lincolnshire, particularly around Grantham A&E, services of Grantham A&E. There is correspondence attached. There's one further piece of correspondence which has been circulated this morning from the leader of South Kesterland District Council. The committee is requested to note the developments and the pieces of correspondence, but also in terms of, if you like, the next steps, to note that we have items listed for the 16th of September, picking up the 2 strands. So the first strand is an update on the restoration plan from ULHT and how the, if you like, patients who are now accessing Grantham from elsewhere and, if you like, the displaced patients from Grantham are being, how that is going. And the second part of that is the longer term, which is the healthy conversation and how the engagement exercise, which was something the committee had been due to consider back in March at its council meeting. So it's to consider the outcome of the engagement exercise as well as considering the next steps in the process of the Lincolnshire long-term plan. Thank you, Chairman.
Thanks, Simon. Councillor Whittington, you'd like to come in on this item?
Yes, thank you very much indeed, Mr. Chairman. I'm just wondering, I know that you've been contacted by a number of people, and you've also written some letters. I'm just wondering if you've had any response to any of the letters you've written, and hopefully when you do, if you've not received so far, will that be dealt with via one of your chairman's announcements, or will it be incorporated into for further reports that are due to come to us on these issues? And the second thing is really around the healthy conversation. Obviously, it's on hold at the moment because of COVID. I'm just wondering, potentially the impact that COVID might actually have on how a consultation future my work, because obviously it becomes very, very difficult now for any organisation to contemplate, road shows and drop-in sessions and all that kind of stuff, because of the social distancing regulations. So I'm just wondering if we could give some thought as to what we would think, what options potentially could be there around engagement. And I'm thinking in terms of virtual engagement. I'm just really any ideas that you've got, that the Vice Chairman's got, any of the other committee have got, as to how we might think the NHS could realistically hold a consultation within the next 6 to 9 months to a year, given the restrictions that we're currently facing. Thanks. Thank you, Mr. Chairman.
Whittington. Yeah, I'll come back first of all on your first point. I haven't had a response as of yet from any of the letters that have gone. I know that Simon has chased the Secretary of State, but we still haven't had a response as of yet. Quite clearly, I received a letter today from Callum Cook, the leader of South Stephen, which we, of course, fully support and we'll be doing our best to ensure we do what we can to move this in the right direction for the residents of Crampton. Of course, once I do get a response, now that we will be on a break until September, I will ensure that we do circulate any responses out as soon as we possibly can. And it will be our meeting in September, where we do have ULH with us to explain how they're moving forwards and so on.
I'm going to turn the volume down.
Okay. And in terms of consultation, I understand that they will be coming to speak to us in regards to how they're going to conduct that consultation item prior to going out. So we will have the opportunity to have an input on what we feel is the right way forward. Simon, anything you wish to add? Simon?
Yes, apologies, Chairman. One of the things that was raised by Councillor Whittington is the leaflets. The means of engagement, and leaflets can be is another option that the committee has considered over the healthy conversation period last summer. I think is that, but certainly we can pick up the issues that are being raised with ULHT and with the CCG next time as part of this. And certainly any correspondence can be circulated during the summer period, well, during August or early September. Thank you.
Simon. Anything further, Councillor Whittington?
Thank you, Mr. Chairman. No, that's fine. But as I say, I just think that the consultation, the format, and police is coming back as an agenda item. But I think everybody's going to have to really get their thinking caps on and come up with something that's really innovative, just so people are aware and feel that they can make a contribution into this process. Now, whether that is a leaflet to every house in the county, that may be a way forward. I mean, in the past, I've advocated a letter being sent to all households in the county with a stamp address envelope for replies. I still maintain that, especially now, given the present situation, that may be the only truly realistic option open to both United Lincolnshire and the CCG. Thank you, Mr. Chairman.
Yeah, thank you, Councillor Whittington. I think I take on board fully what you have to say there, and I do feel that is perhaps the most attractive option moving forwards. Okay, I'm going to put a proposal forward that we note the committee's decision on the 17th of June, and a letter was sent to the Secretary of State for Health and Social Care on the 23rd of June 2020, as attached to Appendix A. 2, note the resolutions passed by Lincolnshire County Council on the 26th of June and South Stephen District Council on the 1st of July on NHS services in Lincolnshire, and in particular those services at Crampton and District Hospital. To note that United Lincolnshire's Hospital NHS Trust is due to provide an update to the committee on the 16th of September on the progress with its restoration plan. And finally, to note that Lincolnshire's Clinical Commissioning Group has been requested to report on the Healthy Conversation 2019 engagement exercise and an update on the Lincolnshire long-term plan for this committee on the 16th of September.
May I second that, Chairman? And I think also that it might help if the letters we have sent nearer the date of the September, if we were to do a little prod to see if we're going to get a response.
We have attempted a prod already, Councillor Brewis, and we will continue.
I know you have, Mark. Just suggesting we give another little nudge.
Yes, indeed. Thank you, Councillor Brewis. Okay, all those in favour, could you please show when Trina calls for the vote, please?
Thank you, Chairman.
Sorry.
Right.
I sounded like it.
Councillor Carl Macy.
For.
Councillor Chris Brewis.
For.
Councillor Bill Bilton.
For.
Councillor Susanna Barker-Milan.
Isn't here, Trina.
Okay, thank you. Councillor Matthew Fido.
For.
Thank you. Councillor Mrs Sandra Harrison.
For.
Thank you. Councillor Rob Kendrick. He left.
For.
Oh, thank you. Councillor Colin Matthews. Thank you. Councillor Robin Renshaw.
For.
Councillor Angela White.
For.
Councillor Mark Whittington.
For.
Councillor Stephen Woodliff.
For.
Thank you. Councillor Linda Wotton.
For.
Thank you. And Councillor Ray Wotton.
For.
So that's unanimous, Chair.
An update on urgent treatment centres in 3 months' time. So those items will be added in and programmed in for October and November as required. Thank you, Chairman.
Thank you. Councillor Renshaw, would you like to come in at this point?
Thank you, Chairman. Yes, it was the there was an unannounced inspection at Pilgrim and the County Hospital in January, and a subsequent report was published by the CQC, which I printed off and read, with a lot of problems in it. So it would be useful if we had a report back from the Health Authority on that.
We can look to chase it up, certainly, Councillor Renshaw. We did have it in front of us, I believe, but I think we should see how they're moving forwards.
Yeah, thank you.
Thank you, Councillor Renshaw. That'll be added to the list. Anything further, any from colleagues? No?
Yeah. Mr. Chairman, I'm just thinking now, with the addition of the extra items, this is now a fairly chunky agenda.
Yes.
And I'm just wondering potentially if we should be planning to possibly have, work up until 1 and then maybe have an afternoon session from 2. But if we get it, if we get the principle agreed now, it would probably reduce us maybe having to rush items through on the 16th. If we've imposed ourselves a deadline of 1 o'clock, to say now that we think this is such a meaty agenda that we will need the afternoon session. Thank you, Mr. Chairman.
Yeah, thank you, Councillor Whittington. We do tend to go over all of this during our pre-meetings, and I would have agreed with you in totality that we will need an afternoon session as well. So we will take that into account. Thank you, Councillor Whittington.
Thank you, Mr. Chairman. Thank you.
Thank you. I'm not sure if Liz Ball is still with us or not.
I am. Oh, yes.
You are? Oh, good. I'm glad to hear it. Liz is retiring from the NHS next month, so this is the last meeting of the committee which she will be attending. Liz has been the committee's special advisor from the NHS, attending each meeting in her role, and I would like to thank her for her contribution over the recent years and wish her all the best in the future. We truly have appreciated you.
Could I join you in that, Chairman? Liz has been almost a feature, a fixture, and her advice has been so much valued over the years, and I can't imagine, is there no clause we can issue saying she's not allowed to go?
That would be very well welcomed. Not from Liz.
Thank you very much, and it's been a real privilege. I've really enjoyed working with you all and being part of your work. I had officially retired at the end of May, but because of COVID, I've extended that. I'm going to have a bit of time off and then think whether I'll return for some more time or not. But I'm just going to have a few months out for the moment. But thank you.
Thank you. You will all be missed, and we do wish you all the best moving forward.
Thank you very much.
All the best.
Thank you.
Okay, thank you. Well, that brings it to a close. I'll just take the proposition on the actions that we're all happy. So I'll propose that from the chair. Do I have a seconder? Thank you, Chris. And all those in favour, I think we'll just take it on bulk. If there's any opposition, just please say now. Yeah, that's taken then. Thank you. That brings the meeting to a close, and I look forward to seeing you all in September.